السلام عليكم ورحمة الله وبركاته. بنرحب بكل المشاركين وكل الحضور. اليوم بنبتدي المؤتمر السادس للأمراض الباطنة من مستشفى السعودي الألماني فرع الرياض. السلام عليكم. Welcome everyone. I am very happy to see all of you right now, and I am honored to start the sixth SGH Riyadh Annual Assalamu alaikum. I am sorry for this interruption. It seems that I have net connection problem. I will repeat again. I am welcoming everyone here from Saudi German Hospital Riyadh. I am Dr. Ahmad Al-Ghitani, Chief and Head of Internal Medicine Department. I am a nephrology consultant. And here from Saudi German Hospital Riyadh, we are launching the sixth annual Internal Medicine webinar. We have 3 days today Today is the first one. We have 2 sessions every day. We will start, each session has a subspecialty. We will start with gastroenterology subspecialty. And I am happy to start with our professor, our dear professor, Professor Dr. Ahmad Turki. He's professor of gastroenterology and hepatology in Theodore Belharis Institute in Cairo. And he's the chief of gastroenterology and hepatology in Saudi German Hospital Cairo branch. Welcome, Dr. Ahmad. You can unmute and start your presentation after I stop sharing my presentation.
Assalamu alaikum wa rahmatullah. And I would like to thank Dr. Ahmed and the organizing committee for inviting me to this respectable meeting. And my presentation is about COVID-19 and the digestive system. The causative agent is the SARS-CoV-2, is abbreviation for severe acute respiratory syndrome coronavirus 2. It's a single-strand RNA virus belonging to the beta subgroup of the coronavirus family. It shares considerable similarity to the SARS-CoV-1 responsible for the SARS syndrome in year 2003. And it is the 7th coronavirus identified with human infection capacity. After naming the virus, the WHO renamed the disease as coronavirus disease year 2019, which with the abbreviation of COVID-19. The epidemiology with all the infections and deaths it caused, COVID-19 will mark a before and after in the history of humanity and the history of medicine. For many, it is a real humanitarian tragedy. The cases reported and also the mortalities, there are about 305 million cases reported globally, 390,000 cases reported in Egypt, 5.5 million cases, deaths reported globally, with a 2% of the total cases. But this is actually a low figure, and the hospital rates is usually in the range of 4%. In Egypt, the reported deaths is 5.6%, which are 22,000 cases. However, the problem of underreporting is a universal problem. And this is an example for 6 countries, where in Russia, for example, the reported cases with only 1/4 of the actual cases. And in UK and USA, it's nearly 1.5 the cases. There are 4 pathogenic mechanisms for the COVID-19 shared by all the organs and 1 specific for the lungs. The different pathogenic mechanisms, including direct cytotoxicity induced by the virus for the invaded cell, overproduction of inflammatory pro-inflammatory cytokines that may end in cytokine storm, activation of the coagulation cascade with the thrombosis, dysregulation of the renin-angiotensin-aldosterone system, and for the lungs, it can also induce lung fibrosis. The first 4 pathogenic mechanisms can be applied for all body organs. The risk factors for severe COVID-19 disease include the age, cardiovascular and cerebrovascular diseases, respiratory diseases, kidney diseases, pregnancy, immune suppression, and obesity. There is no specific gastrointestinal or liver disease that can expose that then lead to or expose the patient to a severe COVID-19 infection, but only the patients under immune suppressions are at that risk. And we are going to discuss that in a few minutes. So I'm going to discuss the gastrointestinal manifestations and complications, the hepatic manifestations and complications, and the drug management, which in gastrointestinal and liver diseases. And this will include a discussion about immune suppression adjustment and short talk about antiviral therapy for hepatitis B and C, acid suppression, remdesivir, and a few words about the COVID-19 vaccines. The gastrointestinal manifestations, any part of the digestive system can be affected by COVID-19. And the GI symptoms are one of 6 symptoms clusters described with the COVID-19, including respiratory, general symptoms, and others. The reported prevalence for GI symptoms in COVID-19 is highly variable and ranges from 11 to 95%, but overall, 1/3 of all COVID-19 patients will present with GI symptoms, and the symptoms include anorexia, nausea, vomiting, diarrhea, abdominal pain, and less frequently, altered taste or dysgeusia. The symptoms may accompany respiratory symptoms or precede the respiratory symptoms, and sometimes the symptoms are only gastrointestinal. In most of the cases, symptoms are mild and short-lasting, but in a minority of cases, symptoms may persist for more than 6 months. And this is a study of 117 patients that were followed for 6 months, and among them, the most persisting symptom was anorexia, followed by nausea and heartburn, followed by diarrhea and abdominal distension, then belching and vomiting, and lastly abdominal pain, and sometimes bloody stools. The gastrointestinal complications include acute pancreatitis, which is widely reported in patients with COVID-19, especially those with critical illness. And few cases were reported to progress to necrotizing pancreatitis. Management is the same as for the non-COVID-19 patients. But the rise of serum amylase and lipase should be interpreted with caution, because patients with gastrointestinal COVID will have a leaky bowel, and the rise in the amylase and lipase may be representing an imbalance between the production and degradation or increased absorption from the leaky bowel. So we have to be cautious and to try to document the diagnosis with other features like imaging and symptomatology. COVID-19 and GI bleeding, in general, the available literature is heterogeneous with a wide range of variation. But in several studies, the reported incidence range between 2 and 4%. And from the available data, we can speculate that patients with COVID-19 has more tendency for higher incidence of GI bleeding compared with non-COVID patients. And the risk factors are the common risk factors, but the use of anticoagulants is a specific risk factor. The mechanisms include the virus-inducing herpetic-like erosions, which is a direct cytopathic effect, thrombosis and ischemic changes, and coagulopathy, and also stress ulcers. Endoscopy is reserved for cases not controlled on conservative management. And gastrointestinal bleeding in general carries worse outcome for ICU admission, death, and composite endpoints. This is a comparison between patients, COVID-19 patients with GI bleeding and without. Patients with GI bleeding have nearly double-fold the cases without for mechanical ventilation, and more than twice for ICU admission, nearly double the deaths, and more than double the composite endpoint. So GI bleeding carries a worse prognosis for COVID-19 patients. Alias and feeding intolerance is reported in many of the cases, about 50% of cases, and the etiology is usually multifactorial. It can be related to the direct cytopathic effect of the virus and also the drugs used like sedatives and opioids. Acute colonic pseudo-obstruction or the Ogilvy syndrome was also described, and the pathogenic mechanism is also direct cytopathic effect of the virus, additional to possible ischemia or associated infectious colitis. Intestinal ischemia is the most serious GI complication reported in critically ill patients. The manifestation could not be classical, as many of these patients are under mechanical ventilation, so they cannot express pain. And accordingly, abdominal distension, increasing leukocytosis, increasing vasopressor requirements, and or unexplained metabolic acidosis could be the presentation. Abdominal CT scan is usually diagnostic. However, a significant number of patients develop mesenteric ischemia despite patent and well-perfusing proximal and mesenteric vessels on CT, suggesting that thrombosis involves the small intestinal vessels. Once diagnosis, management is surgical. Now we shift to the COVID-19 and patients with chronic liver disease. These patients, unless they are under immune suppression, they have no increased risk for acquiring COVID-19 infection, but from 14 to up to 58% of COVID-19 hospitalized patients present with elevated ALT and AST. The range of AST and ALT elevation is mild or moderate, less than 5 times the upper limit of normal. The pattern of elevation in case AST is higher than ALT, this might be linked to a more severe disease. Serum bilirubin and alkaline phosphatase are less commonly elevated than AST and ALT, although ACE2 receptor is more frequently expressed on the cholangiocytes than the hepatocytes. There's no good explanation for that. Serum albumin is reduced in severe cases of COVID-19. Now, the hepatobiliary complications, acute hepatitis is reported, while acute liver failure is usually related to shock liver as part of a multi-organ failure. Hepatic decompensation and high mortality in chronic liver disease is a very peculiar finding. The preliminary data suggests that patients with pre-existing liver disease have worse outcome if infected by COVID-19. Comparing patients without chronic liver disease and those with chronic liver disease, although the number of patients with chronic liver disease is much less than the number of patients without chronic liver disease, but the mortality is threefold higher in patients with chronic liver disease. The mortality among patients with COVID in general is 4%, and for patients with chronic liver disease is 12%. And if these patients will have established cirrhosis, the mortality will be tenfold higher, 40%. And the death rate is also affected by the stage of the disease. So in childbirth A, the mortality could be in the range of 24%. In childbirth B, it's 43%, and in child C is 63%, meaning that about 2/3 of patients with child C if they got COVID, 2/3 of the patients will die. Now, other complication is acute cholecystitis, and this is also commonly reported in patients with COVID-19 and is usually acalcular cholecystitis. For critically ill patients, the management is usually with antibiotics and percutaneous cholecystostomy rather than surgery. Post-COVID-19 cholangiopathy has been reported as a late complication of severe COVID-19. Patients may develop severe progressive cholestasis and radiological and histological features similar to secondary sclerosing cholangitis. Some patients develop progressive biliary injury and liver failure. Now we shift to management of drugs with COVID-19, starting by the immune suppression adjustment in gastrointestinal and liver diseases. The goal of medication adjustment is to reduce the immune suppression during the COVID-19 active viral replication to lower the risk of complications but at the same time, we have to balance the risk of the disease flare, the original disease, for flaring or organ rejection. Liver transplantation patients and other immune suppressed patients who have COVID-19 may have a longer duration of viral shedding. Thus, the strategies for isolation and for testing for clearance may require modification to reduce the risk of spreading of infection to others. For patients with immune suppression, the risk factors for more severe common COVID-19 disease include advanced age, patients with inflammatory bowel disease, advanced age, comorbid illness, and active disease, particularly colonic disease, and the use of steroids, but not biological agent, especially if monotherapy. Patients on steroids and with active disease, particularly colonic, have increased incidence for ICU admission and death rate. As per now, it is appropriate to exert efforts for early detection of active disease, cases with active disease for treatment, limiting steroids if possible, using monotherapy with biological agent rather than combination therapy, and otherwise following conventional guidelines for drug management. Now, adjusting immune suppression in inflammatory bowel disease. For patients without COVID and in remission, we have to do every effort to sustain the remission. We can taper the dose of steroid to keep it in the lowest possible dose, preferably below 20 milligram prednisolone per day, and it's possible to shift for budesonide. Patients with active disease without COVID, it's better to escalate to a biological agent, and in case of failure, surgery could be an option. While patients with COVID-19 infection, they can continue some medication without interruption, including budesonide, aminosalicylase, sulfasalazine, and 5-ASA derivatives. Topical rectal therapy can be maintained. Antibiotics, of course, can be maintained. Antimetabolites like azathioprine and methotrexate should be reduced or stopped. And biological agents for patients with COVID better to be postponed. For steroids, patients with mild COVID-19, the dose of steroids should be reduced, but patients with severe COVID-19, usually they are on steroids in high dose. So usually there is no change in the dose of steroids when patient infected with COVID-19. Patients with chronic hepatitis B, inactive disease, flare of hepatitis B may occur. Patients will be on steroids or Actemra during the course of treatment of COVID-19. So it's better to start prophylactic antiviral treatment for these patients. Now, For autoimmune hepatitis and liver transplantation patients, for patients stable liver transplantations and autoimmune hepatitis in remission, or patients with start disease, or patients with flare. Those without COVID-19, or even with COVID-19 but mild or asymptomatic disease, management is the same as in the pre-COVID-19 era. No discontinuation or adjustment of the standard doses of immunosuppression, and escalation of the doses is possible in case of disease flare. But for patients with moderate or severe COVID-19, or who have leukopenia and lymphopenia, or both, the approach is usually individualized based on the severity of COVID infection, the associated comorbidities, severity of the liver disease, and the medication regimen. Antimetabolites, mycophenolate, and other fibrin are better to be reduced by 20 to 50% of cases, and sometimes can be stopped. Corticosteroids, whether used for moderate or severe COVID-19 infection, or for autoimmune hepatitis and flare, or with acute T-cell mediated rejection of the liver allograft, the dose of corticosteroid is not routinely adjusted. For calcineurin inhibitors, the drug level should be monitored 1 or 2 times per week for the risk of acute kidney injury. Now, for patients under treatment for chronic hepatitis B or C, or will start treatment, there is no any contraindication, and there is no any evidence that the treatment will carry a higher risk for the patient, so treatment should be continued. Now, a few words about acid suppression in patients with COVID-19. In a meta-analysis of 12 studies, including 90,455 patients, proton pump inhibitor use was associated with increased composite poor outcome, but was not associated with increased susceptibility of COVID-19 infection. On the other hand, such worse outcome was not observed with the use of H2 antagonists. At the same time, there are reports describing less COVID-19 related inflammation with the use of H2 antagonists, especially famotidine. Such observation is currently under studying. The positive effect of famotidine may be due to H2 receptor mediated immunomodulatory action on the mast cell histamine cytokine crosstalk, rather than a direct action on the COVID-19 or the SARS-CoV-2. Now, a few words about remdesivir and the vaccines. Remdesivir elevation of the hepatic transaminases have been commonly observed with the use of remdesivir, but the elevation is rarely more than 10-fold the upper limit of normal, and rarely lead to treatment discontinuation. Remdesivir is contraindicated in case the liver enzymes are more than 5-fold the upper limit of normal. Otherwise, the treatment can be continued and the patient can be for follow-up. Regarding the vaccines, the different COVID-19 vaccines are safe for patients with chronic liver disease, and they should receive it as soon as it's available to them. And the immunogenicity of the vaccines among patients with chronic liver disease is not fully studied, but the available data suggests that vaccination was associated with lower risk of COVID-19 in patients with cirrhosis. Thank you very much.
Thank you, Dr. Ahmed, for this nice presentation about COVID-19 and its effect on gastroenterology system. And we are open for questions. Till now, there is no question. I think everything is clear for our 700 attendee. Thank you, Dr. Ahmed, and hope we can see you next year in the 7th annual internal medicine webinar. And please stay with us for the rest of the session. And now We will start with Dr. Iyad Mkawi, consultant gastroenterology and hepatology. Dr. Iyad has a Saudi board in internal medicine and Saudi board in gastroenterology and hepatology. Let's start. Dr. Ahmed, please stop sharing from your side.
Thank you, Dr. Ahmed. Thank you for the organizing committee to invite me to present this lecture. I will give a brief talk about the colorectal screening for colorectal cancer. My name is Iyad Mkawi. I'm a gastroenterology consultant. My outlines for this topic will talk about the epidemiology of colorectal cancer, risk factors for colorectal cancer, screening test and screening guidelines and preventive factor. First, we'll talk about the epidemiology. Colorectal cancer is the third most common cancer globally. In 2018, 0.88 million deaths were estimated worldwide. Colorectal cancer occurring in developed regions like Europe, America, Australia, as compared to the less developed nation. In high-income countries, there is considerable decrease in colorectal cancer incidence and mortality due to rapid screening and improved treatment. The countries with the highest age standardized incidence rate and age standardization mortality rate of colorectal cancer among all sexes were Austria, New Zealand, Mongolia, and Hungary, respectively in 2018. Surveillance, epidemiology, and end result cancer statistic program in 2020 estimated approximately 147,000 new cases of colon cancer and rectal cancer, 8.2% of all new cancer cases, and estimated approximately 53,000 deaths, which is 8.8% of all cancer deaths. Among the 5 major gastrointestinal cancer, colorectal cancer is the topmost cancer with high ASIR in all sexes worldwide. The incidence in younger adults age between 20 and 49 is increasing by 26% since 1990s. But the mortality rate have remained stable in young adults. Younger adults are usually diagnosed at later stage of colorectal cancer and with more advanced histology. That's because patients with a young age unlikely to go for a screening program. Despite the significant relative increase, the absolute rate of colorectal cancer in young still remain low. That's why still there is no clear guideline for young people to go for a screening program. This diagram will show the estimated number of incident cases and death worldwide in both sexes in regard to cancers. We can see the breast cancer and lung cancer as the highest as an incidence, followed by colorectal cancer and the rest of the cancers. In Saudi Arabia, colorectal cancer is the second most common cancer that occurred after breast cancer. In Saudi male, the colorectal cancer is the top most common cancer, whereas third most common cancer among Saudi female. This showed the epidemiology of colorectal cancer in Saudi and the Gulf countries. You can see UAE has the highest incident rate. This one of the journal which showed in the retrospective study the patient were diagnosed with colorectal cancer usually has a regional, most of them has a regional advanced disease. The minority has distant metastasis and localized invasion. In Saudi Arabia, Mecca and Riyadh and Eastern region has the highest incidence, where Jazan and Najran has the lowest incidence. Incidence rate of colorectal cancer is more common in male than female population, where patient above 60 has the highest incidence rate. What are the risk factors for colorectal cancer? We'll talk in details, but briefly, they are genetics and obesity, inflammatory bowel disease as a cause or risk factor, family history, type 2 diabetes, and race. We divide them as modifiable risk factor, including obesity, low fiber and high fat diet rich in red and processed meat, alcohol consumption, smoking, sedentary lifestyle, and non-modifiable risk factor, including age above 50, gender, male more than female, and black more than white, family history of colorectal cancer, personal history of colorectal cancer or polyps, diabetes, inflammatory bowel disease, and syndromatic polyps. Most of the cancer occurs as sporadic, and the rest percentage are genetics usually. Colorectal cancer screening test. I will talk now about the test for screening program. We have sigmoidoscopy, we have CT colonography, and we have a colonoscopy. I will go in details for the test that we can use for detection and diagnosis of cancer and polyp. We have other tests for stool test, FOB, fecal occult blood, FIT test, fecal immunochemistry, and stool DNA. I'll start with non-invasive tests like fecal occult blood, which detect the presence of heme in fecal sample by using hydroperoxidase on the stool sample, which turn the stool sample to blue, which indicate positive. Vitamin C and other citrus can inhibit the hydroperoxidase, which may lead to false negative. So patient will be instructed to restrict vitamin C and other citrus before doing the test, few days. Aspirin and non-steroidal anti-inflammatory drugs and any specific diet does not influence the result of fecal occult blood. Fecal occult blood was shown in multiple prospective studies to decrease colorectal cancer mortality. Was shown to provide sustained colorectal cancer mortality 30 years after screening. Annual FOB screening test reduced colorectal cancer mortality by 32%, where biennial screening reduced mortality by 22%. What is the advantage and what are the advantage and disadvantage? It's a non-invasive test, does not require bowel preparation like the other test. Visit to the clinician is not required. Sample can be done at home even. Disadvantage, the test is to be done annually. Sample collection takes longer time than the FIT test that require 3 consecutive sample over 10 days to 2 weeks. If positive, patient will advise to have further test and further evaluation by colonoscopy. Fecal immunochemical test uses specific antibody to detect human globin. FIT is more accurate than FOB and specific for bleeding in distal GI tract. There is no need for medication or dietary restriction. This is an advantage. In qualitative FIT test, a positive test indicate by changing in color, and quantitative, the test will be positive if more than 75 nanogram. A randomized trial had compared FIT to colonoscopy for colon cancer. Usually, the participant was lower in colonoscopy group and higher in FIT test, and both showed similar result where detection were 0.1%. Colonoscopy group had higher adenoma and advanced adenoma detection rate compared to FIT group. Stool DNA, it's multi-targeted stool DNA test approved by FDA for patient with average risk adult above 45 years. The test is to detect the KRAS mutation, which specific for colon cancer and other genetic mutation. The test is combined DNA plus the FIT test in one kit, which increased the sensitivity to 92% versus 74 in FIT test alone. And also the specificity, 90% versus 96%. A positive test should followed by further evaluation by colonoscopy. A negative test is repeated every 3 years or as per the specific recommendation and specific guidelines and different guidelines. Stool DNA is not recommended for high-risk individual that you should go direct for invasive procedure as colonoscopy. This is a comparison between the other tests and by specificity and sensitivity. As we can see, the sensitivity and specificity are increased with non-invasive tests, especially for detection of cancer, and decreased for advanced polyp or detection of polyp. Colonoscopy is a definitive test for detection of precancerous adenoma and colorectal cancer with high sensitivity and acceptable specificity. It's allowed for detection, biopsy of the polyps of our colorectal cancer, and removal of precancerous polyp or lesion. Several non-randomized studies was found that colonoscopy with polypectomy decreased the risk of colon cancer. A follow-up study of patients who underwent colonoscopy and polypectomy in the National Polyp Study estimated that colonoscopic removal of adenomatous polyps reduced the risk of death from colon cancer by 54%. Disadvantage of colonoscopy. First, with the inconvenience of bowel preparation, most of the patient does not like to take the bowel preparation, and what is a compliance issue also. It's need a conscious sedation as invasive procedure. Colonoscopy procedure risk include the possibility of bowel perforation, major bleeding during the procedure or after, or infection. The risk of perforation will increase with the comorbidities and increasing age and polypectomy. Among frail patients, there is potential for dehydration, electrolyte disturbance resulting from the bowel preparation itself. Availability of colonoscopy may be limited by the need for specialized equipment and trained endoscopists and by the cost. Sigmoidoscopy. Flexible sigmoidoscopy was shown in randomized controlled trial to decrease colon cancer mortality. It is performed every 5 to 10 years or by different recommendation from different guidelines, with or without FIT test every 3 years, a combination. Disadvantage of sigmoidoscopy: if an adenoma was detected in the left colon, patient should be performed full colonoscopy. Flexible sigmoidoscopy does not decrease mortality for proximal colon. Usually we perform sigmoidoscopy, not colonoscopy, as the higher incidence of left colon lesion more than the right colon lesion. CT colonography. Most CT colonography procedures require adequate bowel preparation and gas dissection of the colon by the rectal catheter to obtain the good images and good evaluation for the bowel. Newer CT technique, usually they use a special contrast that help and that replacing the bowel preparation and the need of bowel prep. CT colonography was compared to an optical colonoscopy in 2 large meta-analyses, which showed near specificity and sensitivity, but still with the colonoscopy has higher percentage. Other tests including colon capsule, which is the patient can swallow and send the result or the videos to the wireless machine. Usually for the polyp more than 6 millimeters, the sensitivity is 88, specificity is 82. It is approved for examining the colon in patients with lower GI bleeding also. This is an advantage for its procedure. Colon capsule is not approved as a primary test for colon cancer, and the capsule should be done every 5 years or based on other recommendation. But as it's a new technique, still not approved by many society for colon cancer. So now we mentioned about the different maneuver or different technique or different tests to do colon cancer. So which one we will do and which one is the start? We have different guidelines, and each guidelines are updated frequently. We have US Preventive Services Task Force, which is 2016, National Comprehensive Cancer Network 2017, US Multi-Society Task Force on Colon Cancer 2017. I will go through the American College of Gastroenterology, ACG, which is the latest one, 2020, in details. We have some different terminology I'd like to mention before we start. Who's an average risk patient for colorectal cancer? The patient with absence of inflammatory bowel disease, family history of colorectal cancer, hereditary syndrome associated with increased risk, serrated polyposis syndrome, or personal history of colorectal cancer. Those patients are considered as average risk patient. What is normal colonoscopy? Colonoscopy where no adenoma, serrated syndrome, tubulovillous adenoma, hyperplastic polyp more than 10 millimeter, or colorectal cancer found. So those considered as normal patient. I will come in details. I will mention the definition upon going further. The American College of Gastroenterology guidelines, they recommend screening for colorectal cancer in average individuals starting from 50 to 75 years to reduce the incidence of advanced adenoma, colorectal cancer, and mortality from colorectal cancer. Still, this is the strong recommendation, still under conditional recommendation to start the screening from age of 45 to avoid developing of advanced adenoma or colorectal cancer, but still we're stick to age of 50. Colonoscopy and FIT are the primary screening modality for colorectal cancer. ACG guidelines recommend the following screening test of individual unable or unwilling to undergo colonoscopy or FIT test. We can do flexible sigmoidoscopy, multi-targeted stool DNA test, CT colonography, or colon capsule. Average risk adult in good health with life expectancy greater than 10 years, continue colorectal cancer through age of 75. About the screening of age above 75, it's conditional and it's individualized patient by patient. Patient with a good life, long life expectancy and good health, we can continue up to age of 85. But most of the recommendation and guidelines did not recommend further screening after age of 85. Other option, as per ACG guidelines, we have fecal-based test or stool-based test. We have FIT test, which is done every year. Multi-targeted stool DNA test, which is done every 3 years. Structural examination like colonoscopy every 10 years. CT colonography every 5 years. Flexible sigmoidoscopy 5 to 10 years. Capsule colonoscopy every 5 years. These are the summary. For other guidelines and recommendation, most of them almost the same. The only difference is with the capsule colonoscopy, which is approved by US Multi-Society Task Force, but does not approved by the other society. How to prevent colon cancer? We have an aspirin and other non-steroidal anti-inflammatory drug, cyclooxygenase 2 inhibitor and hormonal therapy, decrease the risk of colorectal cancer and adenomatous polyp. However, there is increased risk of other adverse event, which is outweigh the benefit for most of the patient, like a GI bleeding and other complication, including chronic kidney renal impairment. So we are limited to use those medication. Calcium supplementation, increase dairy consumption, reduce red meat consumption, and increase physical activity. Also decrease body mass index, and statin use are associated with lower risk of colorectal cancer and adenomatous polyp, although most of the evidence is from observational studies. There is no evidence that antioxidant, fiber, and others to decrease the incidence of colorectal cancer or advanced or adenomatous polyp. These are the guidelines. Mainly it's for gastroenterology, what to do when you find polyps and what to do about the finding of colonoscopy. For example, if we have patient who has a normal colonoscopy, we will repeat the colonoscopy after 10 years. Patient with hyperplastic polyp less than 10 millimeter or 1 centimeter still will continue as normal population every 10 years of colonoscopy. Patient with small adenomatous polyp without high-risk feature, still 7 to 10 years. Patient with side-serrated polyposis every 5 to 10 years. And the rest, as we mentioned, it's mainly for gastroenterology to know this table. Thank you.
Okay, thank you, Dr. Riyadh. We have two questions. They are open-ended questions. What are the main reasons for cancer nowadays?
As we mentioned, most of the colon cancer causes are sporadic. We have the risk factors, as we mentioned in the previous slide, that the patient lifestyle mainly is the main reason. Dietary supplement and certain medication are the main reason for or the main risk for colon cancer. But still, we don't know actually what is the main cause of cancer. As we can see, the genetics and the high-risk patient with the family history as taking the lower percentage of the incidence of colon cancer. So most of the cases are sporadic. Maybe some genes we didn't discover, but most of the causes are sporadic.
The second question is treatment of bowel cancer. I know this is a big question, but if you can just, it is away from the title of the presentation. We are about screening, but please give us a hint.
So I will just give outlines for the main management of cancer. So the main management of cancer depends on many factors, including the stages of the cancer itself, a patient and the comorbidities. Usually advanced cases, they will go for palliative as most of the cancer. Localized disease, localized cancer patient will go usually for surgery followed by chemotherapy or neoadjuvant chemotherapy based on the presence of lymph node metastasis or locally advanced disease. But surgery is the mainstay for treatment for colon cancer, plus minus chemotherapy or radiotherapy after that.
Third question, what is the role of occult blood in stool as a screening test for suspected cases?
Yes, for fecal occult blood test, as we mentioned, we usually do it annually to detect presence of heme. So presence of heme indicate presence of high-risk feature like presence of polyp or even cancer. So we're doing the test once it's positive, though it's less sensitive than the new test, fecal immunochemistry test. But still, we are doing it every year. Once it's positive, it's indicate that possibility of high-risk lesion in the colon, so patient should undergo colonoscopy. Usually, we're doing 3 samples, 3 to 4 days apart. Once one of sample positive, patient should go for invasive test with colonoscopy.
How do you think about use of aspirin in very high-risk patients?
Yes, aspirin by the observational studies show to decrease risk of colon cancer, but with the, as we mentioned, with the risk and complication of the medication itself, it's limited to be used in this indication. But patients who are already taking aspirin, yes, it showed to decrease the risk of incidence of colon cancer itself, but not for like a usual preventive to prevent the colon cancer in average risk patient, and doesn't have an indication to take an aspirin itself.
What is the role of genetic screening in these cases?
Usually the genetic screening will start to do the genetic screening in patient who has a family history or strong family history, age below 50, or some guidelines they recommend before 40. Once they have positive family history diagnosed at young age, the other family members should go for screening for genetic test. But above 50, usually we don't send patient. Certain patients who found, when we took biopsy for cancers, we sent for usual some characteristic feature like KRAS and other genetic mutation. Once it's found, we recommend to screen for other family member. But this is not like common to happen. Most of the patients are, as we mentioned, sporadic.
You have mentioned that constipation is a sign of cancer, or we have to suspect if there is constipation. But for how long, and what is the criteria of constipation to be a sign of suspicion?
Okay, for constipation patient, it's alone, it's not like a high risk feature, because many of us because of the sedentary lifestyle, we complain from constipation. Constipation, new onset, progressive constipation, not improving with laxative. This is an alarming feature. Constipation associated with passing blood per rectum. This is another. And constipation with patient above 50, also another indication to undergo further testing like colonoscopy and other non-invasive tests.
You mean if someone have change of bowel habits, this is suspicious?
Yes, so who was normal and suddenly he developed chronic constipation or bad constipation, not responding to laxative, or associated with other symptoms and signs. So those patients should go further investigation and workup. It's not necessary usually to start with colonoscopy. Other non-invasive tests can be done. Then we'll proceed for colonoscopy if the cause unrevealing.
The doctor who was asking about the time when you say it is constipation, I think it is about a change of the bowel habit.
Yes, usually the patient, the constipation itself, it's individual. Like patient has a bowel habit every 1 day, every day, every 2 days, every 3 days. Usually, if bowel movement less than 3 per week, we consider this as a constipation. And if it's prolonged every more than 1 month, we call it chronic constipation.
Okay. Can we find metastasis during the operation that is not found on the CT?
No, colonoscopy itself, it's luminal examination. So we can decide if the patient has mass but we cannot decide if the patient has distant metastasis. We can say for certain patients, if the disease is locally advanced, like if the mass itself, it's invaded the colon, we can mention that. But for distant metastasis, to examine if there is a lymph node or there is mets to the liver or lungs, it's difficult to be done by colonoscopy. Usually we do images, PET scan, CT scan, MRI, to define if the patient has distant metastasis.
What about tumor markers in cancer colon?
Tumor markers, it's not used for diagnosis as it can be misled. Usually as a prognostic test, after the patient had cancer diagnosis management, we follow the patient with tumor markers, CEA mainly, to make sure that there is no recurrence, but it's not used routinely for diagnosis or even to screen the patient for cancer. It's not a good test for screening, but it's used for prognosis and follow-up patient post-treatment.
If we have a patient with iron deficiency anemia and he is male and over 50, does this patient require screening?
Yes. Even if he doesn't have anemia, above 50, this is an indication to do colonoscopy. But if patient below 50 and has anemia, male, especially male, we have to rule out other causes, but eventually patient will end up with upper and lower endoscopy based on the history and the clinical scenario itself. So patient above 50, regardless presence or absence of anemia, he should go for colonoscopy to screen for colon cancer, as this is an average risk patient. As we mentioned from the guideline, and most of the guideline, above 50, he should go for colonoscopy. But below 50 with anemia, if all causes was ruled out and no hematological cause or other causes nutritional, patient should go for endoscopy, either upper or lower, based on the history and the symptoms of the patient.
This was the last question, as I see here. No, there is another question.
Yes.
Why colon cancer is more than others?
Usually we don't know exact the cause of that, but usually from sedentary lifestyle, lack of exercise as a risk factor, obesity, special habit with a special kind of red meat, all of that are the risk factor found to be recently as increased risk of colon cancer. But the actual cause still unknown. Why the incidence was increased? Because we are doing many invasive tests nowadays to diagnose the cancer, which wasn't there before. So increase the screening and increase the test to detect the cancer. This will increase the incidence, of course. But with the screening program, will decrease the risk of colon cancer by detection of the early detection of the polyp and remove it. Which is precancerous. This will decrease the incidence of colon cancer.
This was the last question regarding this presentation. It seems that everyone is concentrating with you all the time, and this is very good. And now we are ready to go for the next presentation for you.
Okay, sure. It's okay. Okay. Again, welcome everyone. I'll present now about gastroesophageal reflux disease and refractory GERD. Hopefully you'll not get bored from me that I'm presenting two talks together. So what is heartburn? Heartburn is a burning sensation in the chest that can extend to the neck, throat, and face. It gets worsened by bending or lying down. GERD is a common disease. I'm referring GERD to gastroesophageal reflux disease. Is a common disease with the highest prevalence in North America. Other systematic review showed the incidence, the prevalence of GERD ranging from 18 to 27 in North America, 8.8 to 25 in Europe, 2.5 to 7 in East Asia, 8.7 to 33 in Middle East. We have a wide range because we don't have like specific studies for Middle East, 11.6 in Australia, 23 in South America. So what is the spectrum of heartburn? Most of the patients with heartburn, they will develop gastroesophageal reflux disease. This is the majority of the patient. Some of them, they will have reflux hypersensitivity, functional heartburn, rumination syndrome, achalasia, or functional chest pain. This is a minority of cases who has a heartburn as a symptoms. So what is GERD? According to American College of Gastroenterology, it's a symptoms or complications resulting from the reflux of gastric content into the esophagus or beyond into the oral cavity, including larynx or lungs. There are three phenotypic presentation of GERD. First one, erosive esophagitis. Second one, non-erosive reflux disease. Third one is Barrett esophagus, which consider also as a complication of GERD. What is the pathophysiology? The main mechanism of developing GERD is by increased frequency of transient lower esophageal sphincter relaxation. So more relaxation, more reflux to the esophagus of food content from the stomach, with or without impaired of lower esophageal sphincter tone or gastric or esophageal motor dysfunction, which lead to GERD symptoms. As we can see in these two images, so this is the normal or healthy patient, and these are the unhealthy or patient with GERD. So most of the gastric content will reflux to the esophagus, and the esophagus mucosa usually sensitive to the acid, differ from the mucosa of the stomach itself, lead to GERD and gastroesophageal reflux disease. What are the risk factors? Overweight and obesity. A patient with the BMI of more than 35 or 36 has 7-fold increase in incidence and prevalence of GERD. Certain dietary habit will come on that, lack of physical activity, the use of medicines such as steroid and analgesia and many other medication, cigarette smoking, and in other data, there is also increase with alcohol. Among lifestyle factors, diet is the most important risk factors for exacerbation of GERD symptoms. It has become common practice of for physician to advise patients to avoid certain food. However, conflicting results exist in the literature regarding which food are reflexogenic. So still all under investigation, no clear data what kind of food, but we know from different observational studies, special diet that can increase the risk of gastroesophageal reflux. Based on clinical observation that fat seems to elicit heartburn, patients are generally advised to avoid fatty meal. Some studies have shown that fat reduce lower esophageal sphincter pressure, which lead to reflux. Alcohol and caffeinated drinks are two other items commonly thought to exacerbate GERD symptoms. Other commonly implicated food include chocolate, mint, citrus, and spicy food. But all still, there is no clear or definitive study that proven these association. So we have the presentation of GERD. We divide it into either esophageal or extraesophageal syndrome. Esophageal syndrome, patient have symptoms but no finding by endoscopy. We call it non-erosive reflux disease. Patient will present with thoracic pain due to reflux. Patient with mucosal disease, they will have esophagitis as a part of their GERD, or complication like stricture, Barrett esophagus, and adenocarcinoma. Patient with extraesophageal manifestation, there is some symptoms that proven association between GERD and extraesophageal symptoms like cough, laryngitis, bronchial asthma exacerbation, dental caries. Proposed association but not proven, pharyngitis, sinusitis, IBF, and recurrent otitis media. Diagnosis, so how we diagnose GERD, we'll come also to that in details. We have barium swallow, we have upper endoscopy, we have pH monitoring, we have manometry, and trial of PPI. So which patient should go upper endoscopy? Patient with alarming symptoms or feature of GERD like dysphagia, for solid mainly, odynophagia, evidence of bleeding like hematemesis or melena, weight loss, persistent vomiting, recent onset of progressive symptoms, patient with iron deficiency anemia unexplained, and if patient has new onset of dyspepsia with the age more than 55 or the presence of alarming symptoms should undergo endoscopy. These are the findings according to what we mentioned, we know, Los Angeles classification. This is also pure for GI people. If we found a small mucosal breaks less than 5 millimeter, we call it Los Angeles classification grade 1. If one or more mucosal break that's more than 5 millimeter, we call it grade B. Less than 75 in circumferential, we call it grade C, and more than 75, we call it grade D. I just mentioned some details about the investigation and the diagnosis or the workup. Usually patient who's presented with typical or classical symptoms of GERD, we give them a trial of PPI. This is the patient symptoms for 8 weeks. If the patient symptoms relieved, so this is confirming the diagnosis of GERD. If patient doesn't remove, we'll go for further test, either by endoscopy to start with if he has alarming features, or we'll do pH monitoring to document the presence of acid reflux. And then to rule out other causes, we do manometry. In regards to barium, barium is not used for diagnosis of gastroesophageal reflux disease. Mainly it's used to rule out presence of complication or other causes like motility disorder. So how to manage GERD? Usually it's preventable by lifestyle modification, and also we can use a medication or other therapies. We have 4 types of treatment. I will talk in this part about lifestyle modification and medication. And in the refractory GERD, I will mention about the surgical option and endoscopic treatment. So lifestyles, patient should better to sleep on the left side with your upper body raised, eat smaller and frequent meal, try to lose weight and decrease your BMI, exercise as much, avoid lying down within 2 to 3 hours after eating, avoid acidic and fatty meals, and medication like non-steroidal, avoid consuming irritating substance like coffee or chocolate, avoid tight clothes and belts. This is in regard to lifestyle modification. The one proven to decrease the incidence are the symptoms of GERD, mainly weight reduction and elevate the head of the bed. Those are mainly to decrease the symptoms of GERD, proven by observational study. About the medication, I will mention about the antacid, H2 blocker, proton pump inhibitor, pro-motility drugs like metoclopramide, and other medication like baclofen. I'll start with antacid. Antacid usually neutralize the acid in the stomach, so there no acid to reflux to the esophagus. The problem with the antacid, their mechanism of action or their effect is very brief and short, so the patient will have recurring of the symptoms. And the best way to take the antacid is approximately 1 hour after the meal. It's the only medication to be taken after the meal, which is just before the symptoms of reflux begin after meal. About the H2 blocker, H2 antagonists are very good for relieving the symptoms of GERD, particularly heartburn. However, there are not very good data for healing of the inflammation, especially in there is esophagitis grade B or C or even D, accompanied by GERD. In fact, there are used H2 blocker. They are used primarily for the treatment of heartburn in GERD that is not associated with mucosal or inflammation, mucosal injury or inflammation or complication. We heard about many problems with H2 blocker recently. As all you know, that ranitidine was obsoleted from the market because it can metabolize to a carcinogenic substance. So we have the other option like famotidine and nizatidine. About PPI, PPI are used when H2 blocker or H2 antagonists do not relieve symptoms adequately or when complication of GERD exists. But nowadays, PPI becoming the first line of medication to be started and the best to be taken half an hour before meals. The reason for this timing is PPI work best when the stomach is most actively producing acid which occur after the meal. So we take it 30 minutes before meal. But don't take it if you're not going to eat because it will have lowest effect as shown in the studies. So how we approach patient with GERD? Usually patient who has classical symptoms of GERD, we give them a trial of 8 weeks, once daily dose of PPI. If patient develop complete relief, we discontinue PPI. And we should make sure that the patient will have a trial to discontinue PPI because of side effect and complication, and we'll come to that later on. If the symptoms recur or patient had incomplete relief of the symptoms, we offer patient EGD of PPI to document presence of mucosal injury, and we manage accordingly after that. If injury, the patient should go under further workup by pH monitoring and manometry to exclude other causes. And if there is mucosal injury, so this is confirming GERD, we can go up with the medication or we can add on to this medication. So what is refractory GERD? So we define refractory GERD that patient with GERD who exhibit partial or lack of response to proton pump inhibitor twice daily. Usually the patient will have heartburn or regurgitation and less than 50% response to double dose of PPI therapy with a period of 12 weeks duration. So those will be defined as refractory GERD by most of the literature. So functional heartburn, this is the most common cause of failure to respond to PPI, and it's not classified as GERD itself. It is estimated up to 58% of patients with persistent heartburn despite PPI therapy, we call them to have functional heartburn. According to Rome 4 criteria, we diagnose functional heartburn if the patient had burning retrosternal discomfort or pain, absence of symptoms relief despite optimal anti-secretory therapy, especially with the PPI, absence of evidence of GERD or gastroesophageal reflux disease by endoscopy, and we rule out other causes like eosinophilic esophagitis and motility disorder. So all of that will confirm the presence of functional heartburn, and we'll come to management of that. So what can cause failure to respond to PPI and the patient doesn't have GERD? We have a differential diagnosis include non-gastroesophageal reflux, achalasia as a cause of dysmotility, eosinophilic esophagitis, a reflux like dyspepsia, and gastroparesis as risk or other cause of unresponding to anti-secretory medication. So possible causes of reflux, this is, possible causes of refractory GERD, we classified according to patient's factor and therapy-related factor. We have the most important things is the compliance, and we have to make sure that the patient taking the medication on time and with the right instruction, which is 30 minutes before the meal, early in the morning. Patient has a motility disorder such as achalasia or dysmotility. Patient has eosinophilic esophagitis as a cause of his symptoms, non-acidic reflux, and psychological comorbidities. Therapy-related presence of H. pylori, nocturnal acid breakthrough, and rapid metabolism of PPI in certain patients, which is rarely happen. So how to evaluate patient with refractory GERD? As we mentioned before, we have to make sure that the patient is taking adequate medication in the right time and the compliance of the medication itself. We can try to switch to another types of PPI, which it's shown to be cost effective after we increase the dose to twice or the double dose. And we can do further workup if the patient doesn't respond and to exclude other causes of GERD itself. So as we mentioned, a patient with partial and no response to treatment, we call them refractory reflux or refractory GERD. So how to manage them? Usually, patient will start with a PPI. When patient has failed to respond to once daily dose of PPI, we shift it to double dose. And we can go for other types of extended release PPI to get the response. Usually dexlansoprazole has shown in the study that equivalent or even more potent than single or even double dose of other alternative PPI, as it's have a long term and should be taken before meal as other PPI, though the study and the recommendation itself that showed dexlansoprazole doesn't affected by the food, but we prefer to be taken 30 minutes also before meal. Switching to other PPI in another common and cost-effective approach for patients who fail to respond to PPI once daily. In multicenter double-blind randomized control study, switching to single dose of esomeprazole was found to have effective as twice daily dose of lansoprazole. So esomeprazole, Nexium is the common medication, as an alternative for patients who did not respond favorably to other PPIs. Those are different type of PPIs, and we can see the dexlansoprazole, pantoprazole, rabeprazole, this is the most potent medication, should be not as over-the-counter medication, should be given by gastroenterology when patient fail to respond to other medication. Again, how to manage patient with refractory GERD medically. Usually we are giving the PPI twice. First of all, we give PPI once daily, and if the patient failed to respond, we increase it to twice daily. Also, if the patient failed to respond, we go for further tests. Mainly, we go for esophageal impedance, esophageal pH and impedance. If it's negative, it's ruling out the presence of GERD, and we have to give symptomatic treatment with tricyclic or SSRI or other medication. If it's positive, so this is mean the patient has an acid reflux and it's true reflux, and we call it refractory GERD. So patients should go for either to add medication or other kind of therapy if failed to PPI, such as surgery or endoscopic therapy. If partial response, we can do combination. We can start with symptomatic relief with the tricyclic or pain modulator. And if failed, we can give, we can push the patient for alternative management as endoscopy or surgical an option. So what are the indications for surgery in patient with GERD? Patient who failed an optimal medical management, non-compliance with medical therapy, severe esophagitis confirmed by endoscopy after ruling out the complication, if patient has benign stricture, if presence of Barrett but without evidence of dysplasia or carcinoma, so patient can go for anti-reflux surgery or procedure by endoscopy. So we have an option for anti-reflux surgery or procedure, either by endoscopy, which is strata, or transoral. I'll come to that in details. And we have a surgical option, mainly with fundoplication and Linux, which is a newly introduced technique to manage patient with reflux. So the mainstay for treatment is the surgical anti-reflux procedure. The niacin fundoplication provide a 36-degree, as we can see. We wrap the stomach around the esophagus to called like to make a valve instead of the previous valve. That will help to control the patient's symptoms. Usually it has a good efficacy and symptoms relief in 80% of patients. But the problem with the procedure, patient has a recurrence, which reach up to 20 to 30% after 5 years. And certain patients will have non-response, which is less than 10%, and certain patients will have a complication of the procedure, which is dysphagia, and require endoscopic dilatation after the procedure. But nowadays, it's becoming very effective method as anti-reflux surgery in patients who exclude other causes. Endoscopic treatment, it's a new technique, is introduced recently. Strata, which is done by endoscopy. We are by using monopolar technique, we are just giving like a catheter placed with endoscopy assist over the guide wire, and using monopolar energy, a series of 56 treatment deliver. But the problem recently and recent data did not recommend using it, as still the reported data with this technique is still conflicting, and still they are not, we are not recommended to use this technique. About the transoral incisionless fundoplication, usually we use this technique by endoscopy also in patients who wishing not to undergo for surgery, or patient with the complication and comorbidity. It's still recommended, but the efficacy of the procedure itself is still, we are not sure about it. Linux, which is the new magnet, we're using this technique by surgical, first of all, by putting like ring, like magnetic beads, done laparoscopy at the distal esophageal junction. Usually we use this technique in patients who are not willing to go for surgery. It has certain contraindication if patient has severe esophagitis, or patient has large hiatus hernia, because these will not be effective. The problem with the Linux technique that the patient shouldn't go MRI anymore after because it has a magnetic in the itself, the band itself, it's magnet, so patient cannot go for MRI. What about the use of long-term use of PPI? As we can see recently from the data, the complication and the safety of the PPI. So we suggest patients should advise at the follow to take PPI most effective, PPI are the most effective medical treatment for GERD. The most important rule, we give the lowest effective dose for the patient with GERD. So if patient is taking 40, we shift it down to 20. If patient taking 30, we can cut down the dose, or patient taking 20, we can go for 10 for certain PPI. About the complication, the safety issue, we heard in the data, intestinal infection, pneumonia, stomach cancer, osteoporosis, bone fracture, kidney disease, deficiency in certain vitamins and minerals, heart attack, strokes, dementia, and early death. All of that, we can see many data that consider showing these, but there is no definitive study to confirm presence of all of that complication. So we cannot discourage the patient to take the medication because of these complications unless we have a high quality study to proven the presence of this. I highlight the intestinal infection because this is the only complication that proven can happen with the PPI, especially in older people more than 65 of age. But the rest is still not yet proven to have. I know there is some data they mentioned about the safety and this complication, but most of the data is still not confirming the presence of these complications. So thank you.
Thank you, Dr. Riyadh, for this nice presentation, and we have some questions for you. First question, what about daily use of laxative? Is it okay or not?
So I think this is from the previous lecture. We have different type of laxative to be used for management of constipation. The problem with the laxative, the patient will get used to it. We found some association between laxative and presence of melanosis coli, but which is termed to be benign condition, so it's not affecting the patient. The problem, the bowel will be more relaxed and it will not work unless the patient get laxative, especially with laxative that enhance motility of the colon. So by the time the patient will have to get used to that and will be adapt to that, and the patient will develop chronic and worse constipation if he stops the medication. So we are not encouraging patient to take, especially the laxative that depend on the contractility of the colon. We are not encouraging patient to do that.
What about role of prokinetics in management of GERD?
Yes, we mentioned that. Prokinetic is add-on medication. We are not usually use it as a single medication. Usually we use it as add-on medication to PPI or H2 blocker, such as we can use metoclopramide. It will help to enhance the lower esophageal sphincter contractility and will decrease the incidence of reflux, but it's not used and it's limited use because of the complication on the long term using it. So we can use it as add-on medication, but not for the long term. Other medication like erythromycin, it can cause like tachyphylaxis, and the patient will need to increase the doses by the time. So we're not recommended to be used as a single medication.
What about the use of PPI, especially the long-term use of PPI? Will we suffer from long-term side effects like something related to chronic kidney disease? Is it immunological? Is it dose related? How to balance the use?
Okay. So I'll just go back to the last slide. As we mentioned here, long-term use of PPI with certain low-quality studies shown to has a lot of side effects. So how to deal with that? Usually, as we mentioned, we go with lowest effective dose, can cause relief of the symptoms, so the patient will continue on that. What about the side effect and how to manage? Patient who doesn't have risk of osteoporosis, for example, or has no risk factor or add-on risk factor like bone fracture, we don't recommend to use regular vitamin D or calcium or other medication to prevent these complications. Patient taking, like for example, young adult, medically free, is taking long-term PPI like 5 years or more. Do we check creatinine frequently? No. If he doesn't have a frequent, if he doesn't have any other alternative or other add-on risk factor to develop chronic kidney disease or complication like diabetes or other, or he's taking a non-steroidal regular, we don't recommend to routine check for chronic kidney disease. So I know the risk factors I know the side effect proven in certain study, but it's not yet like a high quality study to provide that patients should avoid the PPI taking. Lowest effective dose to be taken, and that's it. No need for routine checkup for creatinine, no need to routine for checkup for vitamins, B12, no need if the patient doesn't have other risk factor to develop all of that complication.
So this was the last question. And thank you, Dr. Riyadh, for this nice presentation. And I hope we can see you in the next webinar, inshallah.
And thank you, everyone. For
and now we are happy to announce for the next presentation by Dr. Ibrahim Al-Razouk. Dr. Ibrahim Al-Razouk is the head of Gastroenterology and Hepatology Department in King Saud Medical City, and he will present to us a very nice presentation about lower GI bleeding diagnosis and management. And also for those who are interested in our webinar and presentation by Dr. Ibrahim, we will have a very nice, interesting presentation about probiotics, but it will be on Thursday around 6:30, inshallah. We will announce for the change in the program. And now we will invite Dr. Ibrahim to present himself and start sharing from your side.
Assalamu alaikum. Do you hear me, Dr. Ahmed?
Dr. Ibrahim, I can hear you. You will find in the panel down a green icon called share screen. You can just press it. Yes, we are watching your screen now, and you can start.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. Thank you, Dr. Ahmed, and organizing committee of Saudi German Hospital to invite me to speak about this important topic. It's lower GI bleeding. It's a life-threatening condition, and it costs the hospital and patients a high burden of economic and health comorbidities. I have no financial disclosure to announce. Okay, so my outline is I will speak about introduction, then epidemiology of the globe and the local epidemiology of lower GI bleeding, and the most common sources or etiology of lower GI bleeding, classification, and clinical features, how patients present with lower GI bleeding, and the diagnostic investigations, as well as management. In addition, we'll just speak about prognosis. So lower GI bleeding refers to bleeding from the GI tract distal to the ligament of Treats, which is mentioned here. It's like a suspensory muscle connecting the esophagus to the fourth part of the duodenum. Any bleeding comes proximal to this ligament called upper GI bleeding, and beyond it is called lower GI bleeding. Some authorities mention this is a middle GI bleeding, but our concern here is our lower GI bleeding related to the small intestine, basically jejunum and ileum, as well as colon. So the GI bleeding ranges from trivial to massive lower GI bleeding. And the criteria for diagnosing massive lower GI bleeding is transfusion of at least four units of blood within 24 hours, and the patient become unstable. Usually, patient lower GI bleeding is stable in comparison with upper GI bleeding, which usually comes with hemodynamically unstable. But in lower GI bleeding, usually stable unless he has massive lower GI bleeding, which has, as I have just mentioned, loss of 4 units of or transfusion of at least 4 units of blood within 24 hours, and decrease in hematocrit approximately 6 grams or less, and bleeding continues for at least 3 days. In addition, significant rebleeding within 1 week. So epidemiology in the globe, acute lower GI bleeding accounts for 1 to 2% of hospital emergencies, and 5% of them requiring emergent operative intervention after failure of other non-surgical procedures. Annual incidence of lower GI bleeding is 20.5 patients per 100,000, and the male has predominantly has lower GI bleeding compared to the female. Lower GI bleeding is a disease of old patient, is ranging the above 65, usually above 65, but it can happen as younger than this age. Epidemiology of the etiology or sources of lower GI bleeding. Diverticulosis comes first, and the other causes remains unknown in 13%. This is based on the nationwide study of US, and it has been shown that hemorrhoids presents approximately 10 to 11%. Neoplasia, or like tumors or polyps, can also be seen in 9% lower GI bleeding, coagulopathy 4%, and angiodysplasia or angiectasia is presenting 3%. Now, this is the globe, and we have also similar finding in other studies in Asia and in Africa, 2015 and 13, and from 2007 to 2015, the hemorrhoids comes first as the most common. When I say hemorrhoid, it's usually internal hemorrhoid, and it represents a larger proportion of patients, approximately 1/3 of patient has bleeding hemorrhoids. Then the carcinoma, as well as unidentified causes. However, in the local studies we did in our hospital is referred is a center where more lower GI bleeding seen and upper GI bleeding seen. We have dedicated hematemesis and melena unit, or lower GI bleeding unit and upper GI bleeding unit. So we had this retrospective longitudinal study. A total of 1,137 patients were included in this study, and 178 patients were excluded to missed or incomplete medical records numbers, leaving a total of 959 patients. So 60% of these patients were male, and 40% with them 40% were female, and median age is 52. Well, most patients were inpatient, which means that when the patient is admitted, he has high risk of lower GI bleeding compared to outpatient. While 14% of them were referred from other centers. So in addition to this study, we found out that lower GI bleeding, the etiology most commonly the hemorrhoids, representing 38%, colitis such as ulcerative colitis or Crohn's disease, and diverticulosis seen 12%. And neoplasm is not as common as in Western. We have seen 10% of them had neoplasm, and polyp 5%. And 14%, which is consistent with other nations. So the etiology of lower GI bleeding can be classified as per anatomy, and vascular, and inflammatory, and neoplastic. So anatomic classification could be hemorrhoid or anorectal, and diverticulosis is due to also vascular cause, angiodysplasia, ischemic colitis, radiation-induced, or aortocolonic fistula. Inflammatory, as I mentioned, infectious causes, and non-infectious causes like inflammatory bowel disease. Neoplastic, colorectal, and cancer, colorectal cancer, and polyps. The classification can be also, the etiology can be classified as from on the site, and the site, colon representing the highest source of lower GI bleeding, and the small intestine up to 10%, and upper GIT or a brisk lower GI bleeding can be seen in 15%. Especially when the patient comes with the hemodynamically unstable. So these are pictures of bleeding sources of lower GI bleedings. So this is hemorrhoid, internal hemorrhoid, and this is bleeding diverticulum. We rarely see active bleeding diverticulum. Whenever we do colonoscopy, we usually see bleeding. We don't know where is the source. So, but you can see from here the source of bleeding diverticulum. So angiodysplasia, one of the rare causes of upper or lower GI bleeding. It is acquired mucosal or submucosal telangiectasia of degenerative origin. It is usually associated with aortic stenosis, Van Willebrand disease, chronic renal failure, and usually seen in the colon, it will be seen in the right or in the small intestine. Usually we see it in the small intestine, but if present in the colon, we see it on the right more than the left. Neoplasia or polyps. So it does bleed, and this is sometimes one of the causes of acute lower GI bleeding. how it does happen through the ulceration or invasion into the colonic wall. Other causes, as I mentioned, inflammatory bowel disease, ischemic colitis, infection colitis, and radiation-induced colitis or colonic or post-procedural colonoscopy, post-polypectomy, or post-surgery, or any intestinal surgery can cause lower GI bleeding. Clinical features. So patient may present hematochezia. This is the most common. Is approximately 80% of lower GI bleeding present with hematochezia, and sometimes with melena. Anemia. If it's acute on top of chronic, also can cause weakness, palpitation, dizziness, and syncope. However, patient can present with life-threatening lower GI bleeding. That is, the patient will become in shock. A hint in the knowing etiology of lower GI bleeding, sometimes some patients present with abdominal pain, which goes with the ischemic colitis. And both medical history and procedures needs to be mentioned by a doctor, that he has to mention if there is a recent polypectomy or recent colonoscopy or bleeding dyscrasias. History of risk factor, including bleeding or previous bleeding, for example, diverticulosis, recurrent bleeding from diverticulosis. This should be mentioned in the history. Radiation and use of non-steroidal inflammatory drugs can cause peptic ulcer, can cause lower GI bleeding, massive lower GI bleeding. However, anticoagulant, other drugs like anticoagulant, liver disease, HIV status, and family history of colon cancer or recent weight loss are also important to mention in the history. So here, many residents and many doctors actually in the ER, our colleagues in the ER, they are confused with the maroon color, melena or fresh PR bleeding. This is on your left side is a fresh PR bleeding, which means acute or local cause of lower GI bleeding. That could be anorectal or any pathology in the left colon or transverse colon. However, in between this color is a maroon-like stool. The patient may present with this type of lower GI bleeding. So both of these is called hematochezia, and so it's important to mention that maroon-like is related to a pathology on the right colon or cecum. On your right side, this is clear melena, and it most likely the upper GI source. And it's very important to know these type of lower GI bleeding, how the stool color can help us in deciding the type of procedure. If patient present with this on your right side, melena, then we'll do gastroscopy, and if present with this on your left side or in the middle, we will guide our procedure to do colonoscopy. So hematochezia associated with hemodynamic instability. If patient has a massive lower GI bleeding, it should lead to consideration of brisk upper GI bleeding source and peptic ulcer disease with liver disease or portal hypertension, and using antiplatelet or anticoagulant medication. So clinical feature that could point to the cause of lower GI bleeding: external hemorrhoid with bleeding, usually present with painful PR bleeding, and sporadic low volume dropping 1 ml each day can cause anemia, and sometimes it presents at the end of defecation. Hemorrhoids can be caused by constipation, causing compression on the venous plexus in the anorectum and causing tortuous veins and then lead to bleeding. So internal hemorrhoid is a painless PR bleeding, and it may vary from low to high volume. Diverticular bleeding is a painless, is well associated with sometimes cramping, but painless PR bleeding, and it is episodic and sometimes causes high volume lower GI bleeding associated with clot. And usually it is seen in the 6th decade. Angiodysplasia is again painless lower GI bleeding. It can be overt or occult GI bleeding. Well, it is usually, as I mentioned, some group of patients associated with chronic renal failure or other comorbidities like aortic stenosis. Colon cancer usually causing painless chronic GI bleeding associated with weight loss, and probably there's a family history of colon cancer. A trauma, patient may have trauma to the abdomen, and then the trauma is complicated by injury to the colon and may cause lower GI bleeding. So physical exam should involve the anorectum. If there is no examination of anorectum, means there is a poor history, and there's it's not easy to guide you to which procedure to do and which site of bleeding to be localized. So oropharynx, nasopharynx, in order to rule out upper GI sources. In general physical examination to see if the patient has a shock. An abdominal examination may have a pain related to the ischemic colitis. And a part of the examination, NGT should be inserted in lower GI bleeding. Once the NGT inserted, it should be followed by gastric lavage with saline or water. Once patient has bilious gastric lavage, which this is usually exclude upper GI source of bleeding. However, if there is again blood-stained gastric content, then this may guide us to do gastroscopy first. Gentle digital rectal examination with proctoscopy is also mandatory for patient with presenting with lower GI bleeding. So, in order to manage patient with the acute lower GI bleeding, we need to stratify the risk who are candidate for admission or for ICU admission or general ward. So many criteria, but the validity of these criteria are modest. There's no strong evidence to support one specific criteria compared to upper GI bleeding. So in general, risk factors for acute life-threatening lower GI bleeding are those based on these studies that's in front of you, that just mentioned on the table, that it's continuous bleeding with systolic blood pressure less than 100, PT increased, as well as altered mental status. The many studies has shown different but almost similar risk factors, which is summarized in this slide. So as I mentioned, Occult score is one of these criteria which has been implemented in other centers for less than 8 points. This suggests that patient may not need admission, and more than 8, patient has to be admitted. However, as the evidence is weak to implement it in all the hospitals. If patient has hemodynamic instability, this is a risk factor for massive lower GI bleeding. particularly if he has ongoing GI bleeding with comorbid illness, as I mentioned shortly, liver disease, portal hypertension, renal failure, and age more than 60 with history of diverticulosis. All of these are risk of acute, life-threatening or massive lower GI bleeding. So management, resuscitate. Any doctor, basically in the ER, should resuscitate patient with presenting with lower GI bleeding before calling other colleagues or before referring patient, before doing the investigation. Risk assessment is mandatory where this patient will be admitted in general ward of ICU or dedicated GI bleeding unit. If patient has to be on vasopressors, or if patient has or needs, of course, he needs urethral catheter in order to keep him, to calculate intake and output. Patient may need blood transfusion. They need to do a CBC immediately, which may take time. Do ABGs that could tell you in 80% accurate compared to CBC, the level of hemoglobin, so that will decide how many units of back RBC to be transfused. On the other hand, FFP, if we see higher enough, reassessment and monitoring is also, every hour we have to reassess and monitor the vital signs. If patient initially has mild lower GI bleeding, then suddenly had or developed into massive lower GI bleeding. Urgent colonoscopy or colonoscopy should be informed early. Investigation, full blood count plus ABG. ABG is fast, within 2 to 3 minutes, will tell us the level of hemoglobin rather than waiting for long for CBC or full blood count. Blood grouping and cross-matching, electrolyte, urea, creatinine, lactate, elevated blood BUN to creatinine ratio may give us or point to upper GI source of bleeding. LFTs and clotting profile also can point to the upper GI source. And diagnostic investigation, most of these overlap as diagnostic and therapeutic measures. They include CT, colonoscopy, angiographies, then radionuclide imaging. Each of this has a merit and demerit. CT as triple phase CT scan using IV contrast is safe and fast and accurate with accurate diagnostic tool. Criteria for identification includes vascular dilation and extravasation and hyperintensity with peri-bowel fat. Presence of diverticula is not enough for localization. Many patients has a diverticulosis, but they are not bleeding. And many patients has hemorrhoid, but not bleeding. So it's very important to exactly localize the source of bleeding, not only the finding of or incidental finding of our question mark pathology of GI bleeding. So comparable identification rate to mesenteric angiography and colonoscopy. CT angio, this is different from CT with IV contrast. It's cost-effective, accurate, and rapid tool in the diagnosis of acute lower GI bleeding. Studies report pooled sensitivity of 85 to 89% and specificity of 74 to 96% with BP value of 98%. When combined with visceral arteriography, it increases diagnostic localization. And it can track vessel, identify exact bleeding vessel. It, however, requires that bleeding is at a rate of 0.3 to 0.5 ml per minute. CT angiogram, it has an advantage. It's that it's non-invasive and good localization rate, provides anatomic detail, no bowel preparation is required. However, disadvantage require active bleeding as I mentioned, 0.3 to 0.5 ml per minute. It has no therapeutic option. At the same time, it has radiation exposure with IV contrast as well. And this is the CT angio showing that diverticular hemorrhage on arterial phase coronal image, as mentioned here. So with the CT angio, vascular anatomy is shown, leading to selective embolization of the feeding artery, which causes diverticular bleeding. So we have the endoscopy, option, and it should be the initial investigational and therapeutic option for lower GI bleeding. We have capsule endoscopy, gastroscopy, colonoscopy, and enteroscopy. Capsule endoscopy is similar to the drug capsule. It is swallowed by the patient, provided the patient was prepared, similar to the colonic or prior to colonoscopy. Patient will swallow and show, and the capsule will send images to the recorder in the belt worn by the patient. This is the images of the capsule endoscopy on our right side. So the colonoscopy, which is the best option for such patient, it should be the initial, and its modality of patient, modality of choice for stable patient. It should be stable patient. It's unstable, there is no rule for the colonoscopy. And if it is massive lower GI bleeding, there is no rule for colonoscopy. Very important to visualize the source. Colonoscopy cannot visualize the source. If there is massive lower GI bleeding, it will be wasting of time. So colonoscopy has an advantage that it identifies the site in 80 to 90%, 80 to 90%, and offers the opportunity of therapeutic intervention, and it is relatively safe. Colonoscopy, unfortunately, needs bowel preparation. Unprepared colonoscopy or sigmoidoscopy is not recommended. Unprepared colon will lead to maybe trauma or misdiagnosis of a finding that's not related to the GI bleeding. The preparation should be fast, from 3 to 4 hours through NGT. NGT, we can give the drugs like other available drugs for bowel prep, 12 ml per minute. It will have a rapid cleaning for the colon, and it will allow us to visualize the colon. What time and how fast we do the procedure? In high-risk patient, a clinical feature and signs, symptoms, ongoing bleeding, colonoscopy should be performed within 24 hours, preferably in 12 hours. If patient prepared well, another patient colonoscopy should be performed next available after a colon purge. So endoscopy homeostasis therapy, what does this colonoscopy can do to stop the bleeding? It includes bipolar probe coagulation, epinephrine injection, hemospray, recently added to the guidelines, clip application, argon plasma coagulation, and tattooing. Tattooing may help the surgeon if not successful. Clipping with tattooing can help the surgeon in order to identify the source of bleeding. Provided to patients with high-risk endoscopy stigmata of bleeding, active bleeding, non-bleeding, visible vessel, or adherent clot. So all of these high-risk stigmata of bleeding should be treated. Diverticular bleeding, we use endoscopic hemoclip in combination with the epinephrine. Angiectasia bleeding or telangiectasia or angiodysplasia, we use non-contact thermal therapy using argon plasma coagulation. post-polypectomy bleeding, we use hemoclip or contact thermal therapy with or without combined use of diluted epinephrine. So colonoscopy advantage, it has high sensitivity and requires skilled endoscopist, urgent and emergent. So very important. It's not good for any doctors who have less experience to manage lower GI bleeding. It should be, the endoscopy should be skills to identify and treat such bleeding lesions. So it has advantage. It can be treated. It has an option of treatment. It's not only diagnostic. It has a comparative advantage in massive lower GI bleeding that has stopped. And it is available, almost available in all secondary or tertiary hospitals. The disadvantage, it needs bowel prep, it takes time, maybe 3 to 6 hours. As I mentioned, the colon should be prepared optimally, otherwise complication like perforation can happen during procedure. In addition, procedure needs sedation, which imposes further risk to the patient. Endoscopy hemostasis in specific lesions, hemorrhoids, we offered sclerosant and band ligation. Those who are trained to do this, they can do from gastroenterologists as well as, otherwise it's basically for surgeons. But other gastroenterologists who are trained to treat hemorrhoids can do this. And juice dysplasia, as I mentioned here, we use APC and ejection sclerotherapy. Post-spilectomy, you can apply clips and thermal coagulation and vasoconstrictor like epinephrine and hemospray. Vasopressor to control active bleeding and improve visualization with other second hemostatic mechanism. So this is the examples of bleeding lesions in the colon. So hemorrhoids underwent banding. This is the bleeding diverticulosis, underwent hemoclips. This is bleeding from a polyp, post polypectomy, underwent hemoclip. So sorry for that picture, but it seems that it's important. You know, any lower GI bleeding, this is unstable. See, his tongue is coming on the table and bleeding everywhere. This is not good to have colonoscopy. So colonoscopy should be done in stable, well-prepared patient. So colonoscopy, non-colonoscopy intervention, like our previous patient, they may have angiography. This is useful for patients in whom active bleeding, which precludes colonoscopy or where colonoscopy fails to identify the bleeding site. Angiography and embolization. So elective angiography, patients with multiple episodes of lower GI bleeding without any source of diagnosis. It's also indicated in a patient with massive ongoing bleeding or patient requiring, or patient, So in the angiography needs, patient has active bleeding from 0.5 to 1 ml per minute. Creatinine should not be high, otherwise aggravating renal failure. So creatinine should be less than 1.5 milligram, and glomerular filtration rate is more than 60 ml, and INR should be within the less than 1.5. Platelet should be more than 50,000. Angiography has an advantage of doesn't require bowel prep, can be used in emergency setting, and it has a therapeutic use. So this advantage has low sensitivity, requires active bleeding, complication rate can happen, thrombosis, embolization, renal failure. So this is RBC scan, it's not recommended anymore, and it's wasting of time. It has only a diagnostic option, and has low sensitivity, 25%, and specificity, 27%. So management, as I mentioned, resuscitate and ICU care if massive lower GI bleeding. Upper GI bleeding needs to be excluded. A better examination of anorectal area should be conducted. Localize the lower GI bleeding source as quickly as possible. We need to offer the patient therapeutic angiography or colonoscopy where available or feasible. And if all of these failed, operative intervention is the last option. So resuscitation, I guess all of you knows that needs to actually resuscitate with IV fluid before any endoscopic evaluation. Patient has hypotension or altered mental status, needs to be intubated first, needs to be resuscitated with IV fluid, and blood transfusion needs to be given to the patient if hemoglobin is dropped less than 7, or in case of cardiac ischemia or comorbidities, hemoglobin should be more than 9. And in addition to these, coagulation defects should be managed properly. INR, if it is in therapeutic range, for those patients who are in anticoagulant, endoscopy can be done safely. And we have to correct coagulopathy before endoscopy if patient has a higher therapeutic range of INR. Plasma and blood transfusion should be considered in patients who have received massive RBC. In patient on anticoagulant agent, a multidisciplinary meeting approach may help to decide the best option for the patient. Platelet transfusion should be considered to maintain platelet more than 50,000. So operative reserved for cases in which other modalities fail or unavailable or poorly developed. Selective segmental colectomy following localization is the preferred surgical option. So we cannot send the patient to surgery without doing our best to localize the source of bleeding. Otherwise, patient will have higher mortality, higher morbidity. Surgeon needs to find the source, not to cut everything, not to remove the whole colon. So active bleeding from unidentified bleeding point may require subtotal colectomy and ileostomy. Blind segmental resection is discouraged due to its high rebleeding rate, as well as high morbidity and mortality. So this is the algorithm for management of lower GI bleeding from American College of Gastroenterology. Any lower GI bleeding patient needs to better assist in the emergency department with the vital signs and lab test. If the patient has a high risk based on the amount of blood transfusion and hemoglobin, in addition, he has multiple comorbidities as well as age, and ongoing bleeding, patient needs to be admitted in the intensive care unit or a dedicated GI bleeding unit. Resuscitation IV fluid, back RBCs. The patient bleeding source was identified as upper, we'll do upper or gastroscopy and manage accordingly. Then if patient remains hemodynamically unstable or intolerant to colonoscopy prep, then we'll consult interventional radiologist to do angiography or CTA, and then surgery should be consulted early. So elective colonoscopy after bleeding resolves to identify the source. It's very important to identify the cause of bleeding in order to also prevent further bleeding. If patient becomes stable and no upper GI bleeding per EGD, then colonoscopy can be performed in less than 24 hours from presentation. This is similar to lower risk patients who do not have comorbidities or ongoing bleeding. Then resuscitation also is mandatory with IV fluid and back RBCs, and we'll do colonoscopy after bowel prep. Endoscopy hemostasis, as clearly mentioned to you, they will consider repeat colonoscopy with endoscopic hemostasis for patients with evidence of recurrent lower GI bleeding. Either medications like aspirin, if given for primary prophylaxis, should not be given anymore. Anticoagulants, like given for secondary prophylaxis, should have meeting with the neurology or cardiology in order to decide the best timing of resuming such important medication. So prognosis of patient with lower GI bleeding mortality rate is pretty high, it's 10 to 20% in developed countries, and it's self-limiting in about 70 to 80% without treatment. The rebleeding is common, especially focalization is not done. So it's very important to dig into the investigation and procedure until the source of bleeding is identified to prevent further bleeding or recurrent bleeding. Rebleeding rates earlier, less than 30 days, seen in 14.5% of patients, and new modality and approach have reduced the morbidity and mortality. Conclusion, low GI bleeding can be life-threatening condition. MDT of the endoscopy, including endoscopist, radiologist, surgeon, is necessary for optimal care. Accurate localization of the site and cause of bleeding are critical for focused care. Surgery is increasingly reserved as a last resort. It's my reference, and thank you very much.
Thank you, Dr. Ibrahim, for this nice presentation about lower GI bleeding. Currently, we don't have any other questions. And now we are closing the gastroenterology session. Thank you, Dr. Ibrahim.
You're welcome. Good.
Still, we have in our program another 2 presentations in gastroenterology. It will be in the 3rd day on Thursday, 13th of January. It will be about probiotic and another presentation by Dr. Muhammad Al-Nasser. It will be in the 3rd day as per the program. And now we will close this session and we will start the 2nd session for today. And we are happy to have Dr. Afaf Al-Shammari, our endocrinology consultant in King Abdulaziz Medical City, National Guard. And also she's the president of Saudi Society of Endocrinology and Metabolism. With Dr. Afaf, we have a very nice presentation about obesity as a chronic disease and the challenges of sustained weight loss. Thanks for joining us, Dr. Afaf. Are you here? Dr. Afaf, please, you can unmute.
Yes. Assalamu alaikum wa rahmatullahi wa barakatuh.
Wa alaikum salam.
Thank you very much, Dr. Ahmed, for the introduction. It's my pleasure to be with you here in your internal medicine conference, the 6th one, will be organized by the Saudi German Hospital. Today, I'm going to talk about the obesity as a chronic disease and challenges of the sustained weight loss with the pharmacotherapy. Let me share the slides. I think it's now, is it clear, the slides? So, okay. Is it clear, the slides?
Everything is clear, Dr. Afaf.
Yeah, okay.
The presentation, and I can hear you very well.
Okay, thank you very much. So the obesity as a chronic disease and challenges of sustained weight loss with the pharmacotherapy is the obesity. Today I'm going to cover or go over a view of the obesity as a chronic disease, and the other thing is to maintain the weight loss, and what are the challenges and what are the benefits that is available, and the treatment options, which is the pharmacotherapy. We're going to talk about it soon. The thing is, what is the prevalence of obesity? If we go over the globe, is around 650 million people, they live with obesity. And when they go with the color down, is concentrate on the dark blue, which is more than 30% of the BMI, or the population that are having the obesity, we go with our area. You can see the Saudi Arabia and the Middle East, North Africa, and with the North America is having more than 30% of the population is having an obesity. In Saudi Arabia, when you go, we have like the study on the published by Global Health Observatory data is the trend of the growth of obese people. And the studies showed in 1975 around 10% or 10.8% to be exact, the living with the overweight or obese. With the years going on, is the prevalence of obesity and overweight is increased in our population. And last data that we're having in 2016, 35.4. So around 1 in 3 in Saudi has obesity or overweight. How can we define the obesity, or what are the classifications of the obesity? The obesity is defined as abnormal or excessive fat accumulation that may impair health. How can we classify or define the obesity? The most common one that we use is the BMI. The BMI is the weight per kilogram divided by square meters height. So when we go with the BMI, is actually the Asian population is a little bit lower than international. But here we have normal range between 18.5% to less than 25. When we increase with the BMI increased more than 25%, here we go with the pre-obesity or the obesity pathway. So between 25 to less than 30 is a pre-obesity. More than 30 is obese. And then we classify the obesity as like class 1 and 2 and 3. The last one, 3, more than 40%, which we call it morbid obesity. Is the obesity is a disease? Does it affect the health life or no? The other thing is the question, or only we look at it as the cosmetic, is actually more, or all the international organization, the health organization is classifying the obesity is a disease. When we classify it as a disease, it means it's risk on life and the comorbidities that is whether accompanying the obesity or result from the obesity. So the word obesity here, and when you go with the World Obesity Federation, they consider it as a disease, a chronic, relapsing, progressive disease. Here, Obesity Canada, we classify it or we define it as a progressive chronic disease. The European Association of the Study of the Obesity is a progressive disease, will impact severely on the individual and the society. And the American Medical Association is a chronic medical condition. Is a disease caused by health inequalities, genetics, influenza, whatever it is, or social factors. And here, when you have Asia, is the obesity disease. So most is it's a pathology, it's a disease. So when we classify it as disease, we have to look at it in different perspective and the way we approach people with the obesity. Why we have a risk with the obesity, or what are the diseases accompanied with obesity? It's actually the pathophysiology. When we have excess obesity, this will lead to major risk factor and common chronic disease. How? Is when we have increased adiposity, this will increase in one arm adipokines synthesis, and this will affect the adipose tissue, macrophages, and other inflammatory cells. This will divide, also will lead to the inflammatory cytokines increased and impaired insulin signaling and insulin resistance. And this will end up with type 2 diabetes. When we have lipid productions from the adiposity, this will hydrolysis of triglycerides. And then when one arm, the lipotoxicity will cause NAFL, NASH, or fatty liver, what we call it, and end up with liver cirrhosis. And when they have the release of fatty acids on the other side, as dyslipidemia, this is with the risk with the ischemic heart disease. And eventually, these diseases will cause congestive heart failure, stroke, and CKDs. And the other thing is the adiposity will increase the activity of sympathetic nervous system. And this will increase the systemic pulmonary hypertension. And the adiposity as well increase the renin angiotensin aldosterone, and this is another factor will precipitate or will worsening the systemic pulmonary hypertension. And the mechanical stresses, the main or the most common is the osteoarthritis and obstructive sleep apnea and GERD as well. So we can divide the complications or comorbidities with the obesity as the metabolic, as NAFLD, and the cardiovascular, stroke, dyslipidemia, hypertension, coronary artery disease, and heart failure, and the type 2 diabetes, pre-diabetes, and the mechanical. We can classify when we call it mechanical as GERD and physical inactivity, incontinence, arthritis, and sleep apnea. And the mental or psychological is depression and anxiety. Does this affect the life? Is actually here we can the study being published in Lancet in 2009 showed the BMI when it's normal almost 80%. We can look at the green graph here on the left side, is almost 80% will live till 70 years old. And when we have it on light blue, the BMI increase from 35 to 40, here around 60% will survive to 70. And with the dark blue, when the BMI between 40 to 50, here is almost 50% will survive to 70. So at the conclude, life expectancy decrease as BMI increases. Okay, so we know it's a disease, we know the pathophysiology, we know the comorbidities with it. Do we have, because most of the obese people, they struggle with the weight. Definitely they have multiple trials to reduce weight. The most challenging thing is to maintain or sustain weight loss. This is the most important, that when we sustain it and we have benefits, and what are the options that we can go with to maintain the weight that's been lost. Is the challenges here we can see is the maybe 20s or 30s studies showed all intervention here is on diet intervention, and we can see the people when they lose weight, do they maintain it when they follow them up? Here in the dark blue is the people is when they lose weight on diet only, and when the light blue is when they follow them up from 4 to 7 years. When we go with the left arm, Anderson et al., you can see it's around 30% reduction of the weight with the diet, end of the diet here by kilogram. And then when we go with the follow-up after 4 to 7 years, is actually 5% they maintain the loss. And you can see it here as the Foster et al. Is actually regain weight after 4 years. And here is the reduction or the maintain it is really less than 10%. So this is the things that we're talking about, is the challenge to maintain the weight. What are the options that we can do or to maintain the weight? Here in Saudi Arabia, we have a study that's been done by Professor Al-Fadda in King Khalid University Hospital, as they enroll around 1,000 people with the obesity, and they look at for them for the weight loss when they lose weight, and they follow them over 1 year. And what they find is the 61% of the 1,000 people, they lost more than 5% of their weight. When they follow them up, around 5% out of 61%, they maintain the weight loss. What about the 25% of people, they lost more than 10% of their weight? Only 3% after 1 year, they maintain the loss that they have it with the weight. So this is one of the things that's showing international or local, the challenges or the struggle they're having to maintain the weight. Is what alter in the body? What are the homeostatic system that making the weight loss or the weight regain is actually, it's not only the energy intake and energy expenditures, it's more than this. It's like hormones and the pathophysiology inside our body that is taking us to whether regain the weight. Is the orexigenic hormones like ghrelin is actually increased. And this will pull us to the eating behavior and hunger, perfect calorie and dense food. So this is the energy intake will increase and take us to the left side with the regain weight. On the other side is the energy expenditures. We can have it with the nervous system when we have decreased CNS activity, and we have the metabolism is decrease the fat oxidation or cortisol, and we have anorexigenic hormones. One of them, the most important or the most famous, is GLP-1 that we're having. And plus the definitely is the energy or the exercise that we're having. So this is the balance that we're having, is which one is taking us to the whether weight regain or weight loss. What is the benefit that when we lose weight? Is the benefit is will affect the comorbidities or the complications, whether reductions in the risk of type 2 diabetes, reduction cardiovascular, improvement in lipid profile, improvement in blood pressure, and the severity of obstructive sleep apnea will be less, and the health quality of life will be improved. Only between 5 to 10% weight loss, this will improve or decrease the complications or comorbidities. Here we look at the graph, the type 2 prevention, around 3 to 10% could achieve or to prevent diabetes. But what happens if the patient is being diagnosed with diabetes? Is there a chance to have remission? Is like early intervention could maintain or reverse the diabetes and controlling the blood sugar. And we can see 10 to 15% of the diet of the losing weight, when the 10 to 15% reduction of weight, this will affect the remission of type 2 diabetes. We can see it with their pharmacotherapy, we can see it with diet, we can see it with surgery as well. And with diabetes, pre-diabetes, 5 to 15%. Dyslipidemia, 3 to 15% reduction will control it. Other diseases is around 5 to 10%, like stress incontinence, GERD, polycystic ovarian syndrome, and infertility. We usually advise patients to lose weight 5 to 10%. This will make them controlling the disease itself or the complications of the comorbidities that they're having. Now we have, when we want to lose weight, is we have three options. Whether we have lifestyle intervention, we have pharmacotherapy, or we have bariatric surgery. So, or devices that we can use. Which one is to use and when to use is actually the diet behavior we have to start with and we have to continue with, even if the patient is having surgery. Because I usually tell my patients is surgery is to start, not to the end. So it's the diet, we have to use it all the way. And the pharmacotherapy from the international guidelines, and when the patient is having the BMI more than starting from 30, is to start the pharmacotherapy. And we know the pharmacotherapy, whether with the adverse effect or being expensive, is sometimes is being restricted in a way or another. But if the patient is having 30 BMI with the diet, is we can add pharmacotherapy. But if he's having the comorbidities, whether diabetes, obstructive sleep apnea, dyslipidemia, as with the lower BMIs, 27 is justified to start or to add with the diet is the pharmacotherapy. If their BMI is more than 40, straight we recommend or be recommended is to have surgery. But if they are having comorbidities, any kind of the diseases that are accompanying obesity, starting from 35, you can refer for surgery. What will happen with the lifestyle is we will lose around 3 to 5%. But the problem is with the diet modifications is difficult to maintain due to metabolic adaptations. And we want more reduction of the weight. If we go with the surgery, more than 25% reduction of the weight an average, but it's relatively invasive and require long-term follow-up. And we know some kind of complications that the patient can develop. So what is in the middle is the pharmacotherapy is between around 8% we could add to the lifestyle modifications to achieve some. If failing, definitely is the surgery is an option. So what are the pharmacotherapy that we're having for the weight is we have phentermine, we have orlistat, we have the phentermine topramide, we have naltrexone is the contraire, we have liraglutide 3 milligram, and now we have on the market is the semaglutide 2.4 Wegovy. Are they available? Is all available in the United States. In the European countries, they have orlistat, they have the contrav, they have liraglutide, and they have semaglutide. In Saudi Arabia, we have the orlistat, and we have liraglutide, and recently is having the semaglutide 2.4 milligram. The most common one that been used, because with the Xenical it failed to maintain the weight or little reductions of weight. It's actually, they're not being used by endocrinologists because of the adverse effect they're having. And the other thing is definitely safe over years, but the problem is difficult to lose weight as been expected from obese people. So but the liraglutide, most of the studies showed is the reduction is more and we can be tolerable. But the thing is, look for the studies more with the liraglutide, which is GLP-1, the scale clinical development program, and we are going to review some of the studies. We have plenty of the studies with liraglutide. It's like obesity and pre-diabetes. We have the weight in type 2 diabetes. We have the prevention of weight regain. We have the obesity with sleep apnea and with the intensive behavioral therapy. We're going to talk about studies now, which is the obesity and pre-diabetes, and the other one is the prevention of weight regain by using the liraglutide. Here, when we have this care obesity and pre-diabetes, is the trial objectives is the efficacy and safety of liraglutide 3 milligram as adjunctive therapy to the diet and exercise, and people with obesity or overweight plus comorbidities without diabetes. Here is around 3,731 participants and been enrolled between June 2011 to March 2012. And it's not a randomized controlled trial and been collected from 27 countries, and the duration of the study around 56 weeks, which is around 1 year with the pre-diabetes, and 68 weeks without pre-diabetes. So those, they are randomized to 2 arms, one arm with using liraglutide, the other one with placebo, and then whether they are having pre-diabetes or with or without pre-diabetes. And all of them, they are at the lifestyle intervention 500 kilocalorie diet per day, plus 150 minutes per week physical activity with both arms. What we got from this study is with the people with the liraglutide is the body weight loss is around 9.2% the people the liraglutide arm compared to 3.5 with the placebo. And by categorizing the weight loss is there around 63%. They lost 5% of their body weight, 33% more than 10% of their body weight, and 14% of the people with the obesity, they lost weight more than 15% of their body weight. And the blood pressure is in systolic -4 millimercury, and the systolic compared to 1.5 with the placebo, and 2.6 with diastolic compared to 1.9, is with the lipid profile is modest improvement actually, but the quality of life is 10% 0.6 compared to 7.7 with the diet only. So as the and with the pre-diabetes, is those are only for the without diabetes. But the people with the pre-diabetes, to see the efficacy with using liraglutide after 160 weeks of treatment in delaying the onset of type 2 diabetes, and people with obesity or overweight with comorbidities, and diagnosed with the pre-diabetes pre-screening, or at the screening, they are having pre-diabetes. So those are randomized, double-blind, and is between June 2011 to March 2015, and collected from 27 countries. What happened with those people, the participant with this, when we follow them up, is actually both arms, they lost weight. But when we follow them up after 160 weeks, they found reduction of prevalence of diabetes around 79% on the arm for liraglutide compared to the placebo. So this is what makes the things is weight loss and maintaining weight loss. This will prevent the prevalence of diabetes. What about maintaining the weight? Is here is the see the liraglutide would be achieved with weight loss when they are in diet. Low caloric diet is 1200 to 1400 calories per day, and increased physical activity 150 minutes per week. So what happened is to observe them, those people with obesity alone, and how to maintain their weight loss is actually here is when the mean baseline weight is 99.6, and you can see with the brown color is the diet, and the blue color is the liraglutide. And you can see the reduction is around 6.2% on the liraglutide pharmacotherapy compared to minus 0.2 on the diet only. This is after 1 year, 56. And then when they observe them after they stop the trial and follow them up around 12 weeks after, the one who lost the 6.2% on the liraglutide arm is regained around 2%. So end up with the after off a trial as around reduction of the weight 4.1%. As a matter of fact, the people with the diet, when they stop the trial, is the regain 0.3. So this is showing is the diet alone is not enough, or the most important thing is when you follow them up later on, which arm is regained, which arm is the maintain their weight loss. And then is actually with the achievement of those people around more than 5% weight loss is 50% of population using medications, and around 21.8. And the same is not the same, is actually is around less than third is losing more than 10% compared to the diet alone, 6.3%. But the before I go with this, the most important is the as I mentioned is maintaining weight loss, because when we maintain weight loss, it means we keep on controlling the comorbidities. We try to prevent the diseases, or at least to delay the progression of the disease that we have. The category, if we want to choose, is the and who is going to respond when we treat them with the medications. Who predicts the response to pharmacotherapy? Is actually most factors do not predict a good treatment response. Which one is going to respond? Except early weight loss. So the early weight loss, we can label them as early responder, and those who achieve more than 5% weight loss from the baseline at week 16 on liraglutide compared with those don't respond an early responder. So with the two arms comparing people with the both of them, they are receiving liraglutide, but they observe them after 16 weeks. The one who lose weight up to 16 weeks is, you call it early responder, is actually those people who continue to lose, and those they can get benefit from liraglutide. The one who is not responding or losing weight at the beginning will not lose, or they will lose little compared to the good responder. So here is the good responder, the one who having 16 weeks losing weight, they maintain it compared to the one who is poor responder. So here we can see those are those are with the week 16 when they lose weight. Those are the good responder, the dark blue, which is they continue to lose after 1 year around 11.5% of their body weight after 1 year. The one who lose little at week 16 by using the liraglutide, you will end up after 1 year 3.8. So does this worth it? So it's more important medications, and we know the good responder is the first 3 to 4 months. If they don't lose well, you don't have to continue, or at least you have to go for other modalities, which could be a surgery rather than to maintain or to give medications, which is a bit expensive and injectable one. The one that we're having now as GLP-1 weekly is the same. It's costing around $400 a month. So when you keep and continue using medications, and you know he's not responding or she's not responding at the beginning, I think it's a waste. And from cost point of view, is to give the patient with the end up, like if they start with 100 kilo and after 1 year you lost around 3 to 4 kilos, that's not worth it to give injection, and with the a bit expensive compared to the surgery. The surgery is more expensive. Is like an aggressive, but you would like to maintain the weight. Even with the surgery, regain the, we have seen people with the clinic, they are with surgery, any kind of surgery with a sleeve, any bariatric surgery, you're free of diabetes or reverse the diabetes. After 3-4 years, regain weight, you go back with diabetes with a problem. Even the regain weight will happen with the surgery. So it's less than and more, slowly they regain weight after 4 or 5 years, or some of them after 10 years, but still the regain could happen unless they change their lifestyle. So the bottom line is to conclude with this, the obesity is common, the prevalence is increasing. The second thing, it's a disease. A third thing is accompanied by comorbidities that we have to deal with. The fourth thing is to weight reduction with an average of 10 to 15% will improve the comorbidities. The fifth one that we can the challenge to maintain the weight, and what are the modalities to use and for how long we'd like to use. Thank you.
Thank you, Dr. Afaf. Now we will go for the question and the answer session. We have only one question here, asking permission to have the slides of this presentation. But after your permission, I will say that we have a YouTube channel. You can see and hear the presentation again, this presentation, but I don't think that we can share the slides.
It's okay. Yeah, okay. Thank you.
Okay, Dr. Afaf, do you have any other comment?
No, thank you. If there is no question, I'm fine.
Thank you. Thank you, Dr. Afaf, for sharing us your experience in this presentation, and hope to see you again in the next year webinar, inshallah.
Thank you very much for giving me the opportunity to be part of your prestigious conference. Thank you.
Thank you. And now we have Dr. Ahmed Al-Mutawi. Dr. Ahmed Al-Mutawi is a consultant endocrinologist and associate professor of internal medicine and endocrinology. We will have one presentation now about management of prolactinoma. Dr. Afaf, can you please stop sharing from your side? And Dr. Ahmed, please start sharing your screen.
I already did. I stopped sharing.
Okay, shukran, Dr. Dr. Ahmed Al-Mutawi, can you please start sharing your screen? There is, in the bottom of the Zoom account, you will have a green icon, share screen.
السلام عليكم.
وعليكم السلام ورحمة الله.
طب أنا خليني أجرب أسوي شير سكرين. تضبط معي؟
تفضل.
مضبوط صح؟
دكتور محمد، تفضل يا دكتور محمد، حضرتك
أنا سويت شير سكرين.
تمام مظبوط دكتور محمد، مفيش مشكلة. طيب استاذن حضرتك بس ستوب شيرنج عشان ابتدي مع دكتور احمد المطيبي.
دكتور احمد كيف حالك؟
حياك الله دكتور محمد.
انا كنت فاتح هذا ورحت وجيت احسب ان ما انتبهت انك موجود فشكلي قطعتكم.
حياك الله دكتور محمد.
الله يعطيك العافية.
دكتور احمد the screen is yours.
طيب ان شاء الله بس دقائق دكتور.
take your time مفيش مشكلة خالص.
واضح يا دكتور الان مش سكريني معاكم؟
لا لسه للاسف. ابتدى
كده واضح يا دكتور؟
ابتدى it's loading يعني، بس فعلا دي السكند سلايد. خلاص حضرتك نعمل فول سكرين ونبدا ان شاء الله.
F5 ولا كيف؟
F5 يس.
حطيت F5 بس.
لا هو بطيء شويه، معلش دقيقه بس هتظهر معاك.
كده واضح؟
تمام. طيب احنا مع حضرتك لمده نص ساعه ان شاء الله، وبعد كده عندنا الكويستشنز اند انسر.
بسم الله. نبدا دكتور؟
اتفضل حضرتك اتفضل.
اسف
شكرا.
ممكن عنده سكرينينج ستوب شير. واضح الان دكتور محمد؟
تمام دكتور احمد، احنا مع حضرتك اهو.
بسم الله الرحمن الرحيم. I want to thank Dr. Ahmed and your community to give me another chance in this high quality, very informative meeting. And I want to thank all our colleague and my senior in endocrine instruction, like Dr. Afaf, for nice presentation. Now, actually, we'll talk about some common problem we're facing in our clinic, and also our colleague in Obs-Gynae can also facing that problem as hyperprolactin level or hyperprolactinemia. Actually, okay, the outline just we'll see some physiology about the anatomy of that prolactinoma and what the clinical manifestation and how can you evaluate the patient. And we'll talk about some management and we'll talk about some specific condition like resistant hyperprolactinemia. Just we'll touch on that in small informations. Actually, all of you know the pituitary gland is the master gland. Is located in Celia and have two parts, and is connected with hypothalamus by the stalk, and nearest to the optic chiasm. This is the mainly good structures. Well, concentrated about the very important clinical anatomy about the pituitary. That slide is nice when you have see the pituitary gland, and this is optic stalk and this optic chiasm. When you have any pituitary tumors and growing severely, he can touch up the chiasm and the patient will appear some visual disturbance. Or when you have laterally and he can touch the internal carotid, maybe it's have compressed or some risk of thrombosis. Laterally, he's I think the cavernous sinuses. You know this nucleus of multiple cranial nerve, third and fourth and fifth, and patient will appear some pulse of that cranial nerve. This is very important to memorize that anatomical location of pituitary gland can be help us the clinical manifestation patient appears. Actually, that's all the blood supply of the pituitary gland, as I mentioned, that's so important to us now. Okay, this is very important we know because the actually prolactin is have multiple factor can interpret with prolactin secretion and can increase prolactin. This make the difficulty to approach and to treat it, which patient need to treat it, which patient need to be sent for MRI, which patient is need just a follow-up. When memorize this from the hypothalamus, the dopamine and TSH releasing hormone, this both of them is an infected pituitary gland and control prolactin. Dopamine is inhibited the prolactin and TSH can stimulate prolactin. This is the clear, obvious, clear to us what the connection between hypothyroidism and hyperprolactinemia. And by the guidelines, you need to rule out hypothyroidism when any patient have high prolactin to make sure does not have any hypothyroidism. Any stimulus like stress, dehydration, sleep, we see it's a multiple factor can affect the prolactin. Even any effect in breast tissue can affect the prolactin and lead to increase the secretion of prolactin. This is just to memorize, see this multiple factor can affect the prolactin level, not only the pituitary gland. And just a small information about prolactin. Prolactin, as you know, is a single chain polypeptide, is as most of the hormone is usually pulsatile secretions during the 24 hours, and his have bimodal patterns is more in the night, and the action is to stimulate milk productions. The normal value is at around 25 nanogram per ml for women and 20 nanogram ml for men. This is the normal evaluate normal value of prolactin. Prolactin is secreted from lactotrophic cells in the pituitary gland and is suppressed by dopamine from the hypothalamus. As I mentioned, the estrogen, a testosterone-releasing hormone, and the growth factor and dopamine receptor antagonist, both of them can affect the prolactin synthesis. This also to memorize the normal physiology and what the factor. The pregnancy through the estrogen, he will stimulate more prolactin secretions. Here, renal failure also can affect the prolactin because it decreases secreting of prolactin through the kidney when have renal failure. Okay, what patient will come to us with the presentation? Most patient came asymptomatic, or the most common symptom is gonadal symptom in male and female. And you know, the hyperprolactinemia, prolactinoma is more common in women than the men. And usually patient came with gonadal symptom like infertility, or decrease, or oligomenorrhea, or period disturbance. The most when have hyperprolactinemia, the most symptom is gonadotropin releasing hormone. When have hyperprolactin, he will decrease GRH, gonadotropin releasing hormone. That subsequently lead to decrease LH and FSH. Subsequently, we will have hypogonadal symptom like infertility and hypogonadism, both in men and female. Sometimes the patient came with a clinical or mass effect from local mass effect, as I mentioned before, when have prolactinoma or tumors increasing laterally or severely, can appear with like cranial nerve palsy, or visual disturbance or headache from local mass effect. Now you can separate the symptom, endocrine symptom like endocrine dysfunction symptom, or local mass effect, or came with a top emergency like apoplexy. That is most clinical presentation bring the patient to hospital. The most common is hypogonadal symptom. When have hyperprolactinemia, dysfunction, well, oligomenorrhea in female, or amenorrhea, or galactorrhea. This is the most important in male, impotence and reduced libido, infertility. Also, in post-menopausal women can appear with osteoporosis, you know, when have LH and FSH decrease, and this patient also have estrogen deficiency, lead to osteoporosis. Some adolescents appear to us like a delayed puberty or short stature, who found have a prolactinoma. Or a patient appear with mass effect like a headache, visual acuity disturbance, cranial nerve palsy, or hypopituitarism, panhypopituitarism if have patient tumors, or acute hemorrhagic tumor like apoplexy. In female, 48% of female came with infertility, 39% will came with headache, 29% with oligomenorrhea. Amenorrhea 10 to 20% after excluding of pregnancy, and then most common is infertility or delay conceive. Premenopausal women, now actually there is a correlation between the prolactin level and the symptom appear to the patient. In the higher normal 20 to 50, patient will came with infertility, have regular cycle, but it's difficult to conceive after 1 or 2 years from get married. This will bring the patient to looking for a second medical advice, why is have difficulty to conceive. This is 20%. But with the prolactin going up 50 to 100, this patient will appear with irregular period like amenorrhea or oligomenorrhea. If the prolactin more than 100 is over hypogonadism, and patient can be with amenorrhea, secondary or primary, and actually like a symptom of postmenopausal, maybe we have vaginal dryness or hot flush because severe hypogonad. Actually, in male, 4% will have infertility. The most common is erectile dysfunction, decreased libido, or galactorrhea. This is the most common presentation in male. Okay, as I mentioned, multiple factors can affect the prolactin level and should rule out the other causes before label this patient have need to, or most maybe his lead have prolactinoma and need to investigate for prolactinoma. This is from Endocrine Society guideline to exclude other cause of prolactin before label patients have hyperprolactinemia or prolactinoma, or investigate for prolactinoma, like a medication, renal failure, hypothyroidism, or other non-functional tumors for any patient who came with hyperprolactinemia. As I mentioned before, the drug here, the most antidepressant drug, anti-ulcer drug, opiate, most of them is affected through the dopamine. It will be decreased dopamine secretion. Subsequently, the prolactin will increase, and hypothyroidism and adrenal insufficiency, and injury or chest wall injury. This is the most three common causes can interfere with the prolactin secretions. And if any patient came to us, should to rule out by the history and examination, this is 3 factors. As I mentioned, the physiological pregnancy should rule out pregnancy if that patient came with childhood aging before label, and any pregnancy to rule out. Should be take a history of what drug she used. The most common antidepressant drug, opiate. This can be significantly increase the prolactin level. After that, if rule out prolactinoma, this is the most common pathological causes for hyperprolactin. Non-functional pituitary is less common. The more common is prolactinoma. Other like hypothyroidism, I mentioned, and chronic renal failures. Okay, what the diagnostic workup need to do for the patient? Actually, after history and examination, we'll take his full history to rule out other cause can increase prolactin level drug, and we'll examination for another stigmata for another endocrine cause like hypothyroidism, any surgery, any stigmata of adrenal insufficiency, history of any pituitary tumor before. This is a history of renal failure or other disease can affect the prolactin level. Okay, this is algorithm. If have hyperprolactinemia, after review the history of the drug, physiological and etiology, always repeated prolactin level. Some guidelines need to be, if not, make sure if your lab is not use a standard method for prolactin measurement, you can repeat it. If normal, this is just subside or excluding hyperprolactinemia. If elevated, should rule out is have no hypothyroidism. If elevated, this patient hypothyroidism and need to do anything just to treat the hypothyroidism. If TSH normal and no drugs, no other physiology, and still high prolactin, to do MRI or CT scan to see the pituitary adenoma. If pituitary adenoma, we'll treat it accordingly. If have micro or normal scan. If normal scan, maybe have hyperplasia, just to follow up with MRI and treat it if have physiological affected or hypogonic. This is also the guidelines from Endocrine Society. A single measurement is prolactin level above the upper limit is confirmed. No need any dynamic test like other hormone, only one prolactin level. When have discrepancy between the prolactin and prolactin level and pituitary tumor, if you have MRI have pituitary adenoma, need to rule out any Hock effect. We'll talk about that Hock effect, and need to do dilution of prolactin. If patient asymptomatic hyperprolactinemia, also thinking of macroprolactin, we'll deal about. Is there 2 differentials if have hook effect and macroprolactin. This actually two specific conditions. When have patient high prolactin, and when already exclude hypothyroid, already exclude other drug affected, and you do MRI and show, for example, micro, and your prolactin level is so high, you're suspected to have macroprolactin. At that level, should have rule out the hook effect. If patient have high prolactin level and an MRI is nothing found in MRI or small adenoma, and the patient asymptomatic, should rule out macroprolactin. This is just to explain what's meaning of hook effect. You know, the immunoassay have antigen and antibody. There's captures like a sandwich, and after that will with reading by machines. If that large prolactin will connected with 3 antibody in 1 antigen, and by that level we're reading from machine as prolactin, and he will connect it as high prolactin level, but actually the prolactin is very low. Just the molecules of prolactin is large. Here the hook effect is there are like 1,000 of prolactin. Is the antigen antibody already saturated with the prolactin, and the sandwich antigen antibody is fully saturated, and multiple prolactin is not connected and not accounted by the machine because it's not have any antigen to capture it. At that level will lead to false negative. You found the prolactin level is low and the masses in MRI is large, actually because saturated. But when you have dilutional of prolactin, lead have time to all prolactin molecules to attach to antibody to have normal or corrected reading. Okay, now have patient with high prolactin level. You take a history and examination. You found have no other endocrine, but you found have drug-induced hyperprolactinemia. How can management? Actually, there is guideline. If the patient is asymptomatic and the medication can be stopped, please stop the medication and follow up the prolactin level. If have patients symptomatic and you can discontinuation of the medication, just discontinue this medication and follow up. But if cannot discontinue the medication and the prolactin is so high, it should have MRI, even if this patient have obvious medications. If not, if you cannot stop this medication and still high prolactin and symptomatic, you recommended to give him a dopamine agonist medication with some follow-up. The most common question come to us from our colleague in Obstingyne, just oral contraceptive pills can affected prolactin level. Actually, their study show that controversial that estrogen level, estrogen containing oral contraceptive pills can really elevated the prolactin is so high, just 20%, and some show that is cannot so effective of high prolactin levels. As I mentioned, if have medication increase the prolactin and you can stop the medication, just stop. If not, just and patient asymptomatic, just follow up the prolactin level. If high prolactin and medication you cannot stop, you can start with a dopamine agonist and follow up the patient. Now, after that, you have confirmed this patient had high prolactin, no other cause other than pituitary. Now need to be localized, the pituitary adenoma, or the most will send him for MRI. will do the MRI to see what macro or macro prolactinoma. If you confirm this is micro or macro prolactinoma, depending on the size of the pituitary. If the mass more than 1 centimeter, this is macro. If below 1 centimeter is macro. After confirm, how can treat the patient? Now patient is confirmed to have prolactinoma. The management of prolactinoma, you recommended of dopamine agonist therapy. This will lower the prolactin. This is the aim of treatment, to decrease the prolactin, to decrease shrink the tumor, to restore the gonad function. This is the both the aim of the treatment, and should be follow up in the clinic in this level, the prolactin level, and the shrink of tumors, and the gonadal symptom restore. Which medication we use? The recommended guidelines, cabergoline is better medication than bromocriptine because is highly efficacious in normalize prolactin and better to shrinking the tumors, and long half-life. You can use it once or twice a week. The second one is bromocriptine. The bromocriptine actually is non-selective. He can affect in D2 and D1, and his short half-life, you need to be used 2 to 3 times a day, and is less effective in shrinking the tumor than cabergoline. Okay, this is I mentioned before. The most important side effect in bromocriptine is GI symptom, nausea and vomiting, the most common. Some has have dizziness and headache, other is less likely. Cabergoline, as I mentioned, is more specific and short half-life, long half-life. You can use it once or twice a weekly, and is the primary pharmacological treatment for aggressive macro and microprolactinoma by Endocrine Society guidelines, and is very effective, even for and less resistant other than bromocriptine. How can follow up the patient? Usually follow up by prolactin level, and through the history and symptoms, see that gonad symptoms restore. If patient came with oligomenorrhea, the period is start to be regular. Male, if have all the gonad symptoms is restored. For adolescents, is have start to be enter in the puberty. This is the prolactin, you start to follow up level after 1 month from treatment, and after 3 to 4 weeks, if you have changed the dose. MRI not need to be repeated in 3 months for macroprolactinoma, and we see the increase the size of tumor. This is our aim of treatment. When patient have continue raise prolactin, they supposed receiving immunologic agent or have a new symptom, need to repeated MRI early than 3 months or 1 year. For micro, with 1 year recommended. For macro, 3 months. But if patient, if in treatment, actually have receiving good amount of treatment, but start prolactin level increasing or have a new symptom, need to be repeated MRI. Visual field examination, yes, should have visual field examination as the diagnosis, and if have patient came to the clinic and follow up, if any symptoms suggestive of visual disturbance, need to visual field examination repeated. More specific, if have macroadenoma and near to the optic chiasm. Okay, when you can stop the medication, if have all your aim is conceived, if tumor is shrinking, symptom restore, prolactin level with the normals, then at that time you can start to withdraw the medications. Prolactin level normalize, no tumor in the MRI, or at least decreased by 50%, and his in the 2 years of medication start to be withdrawals, the medication gradually. Sorry, but there is high recurrence rate in macroprolactinoma than the microprolactinoma, and in macro almost 93% recurrent, but in micro only 60%. Measurement of after stop the medication, you can't follow up the patient prolactin every 3 months in the first year, then annually thereafter. MRI no need, except if have prolactin increase above the normal, need to repeat MRI. And if have repeated MRI found other tumors and prolactin levels is increasing, should restore the treatment and or thinking of other modality of treatment. Rare cases have resistant. Resistance meaning of patient receive maximum dose of dopamine agonist for max 2 years and is not drop in prolactin level more than 50%, and the tumor also is not shrinking and still have symptom. This patient labeled as resistant prolactinoma and need to thinking for other modality of treatment. This is the definition of have is not normal, failure to normalize or drop more than 50%, and failure to reduce the tumor less than 50% with maximum dose. This label him as resistant prolactinoma. The recommended resistant prolactinoma to refer to surgery or radiotherapy. This is the second and third modality of treatment. If failure to control, sometimes there one study showed if change from bromocriptine to cabergoline will be a response. If increase the dose of bromocriptine also can some able of improvement of resistance. That's actually if have resistance, the difficulty to control it. There is a new medication like anti-reflux agent, temozolomide. This use it, and in high-grade glioma, show to be effective in resistant prolactinoma. And actually, our colleague in King Faisal and King Fahd, like a Dr. Musa al-Malki, have some patients used that and found to have response of respond to that medication in resistant prolactinoma. If have resistant, I preferred, and even the endocrine society guideline prefer the surgery than the radiotherapy, because the surgeries have more responsive. But surgery will have a complication of hypoparathyroidism. Other indication of surgeries have mass effect, even if it has responsive, with cranial nerve palsy or resistance or intolerance to medication or have apoplexy or have cystic tumor. This is all indication to surgery. The surgery that will not to be talked about it, and long-term chemical cure in surgery is 90%. Even comparable of economic cost of surgical than pharmacological 10 years period show that surgery is cost effective in some patients. Macro adenoma, even like a definition of less than 50%, not cure rate not to drop by 50% is labeled as resistant. Sometimes difficult to do surgery just to do debulking of the tumor, and found to have after that the patient respond to medical treatment. The second thing, radiotherapy, is gamma knife, and you show to have a good effective resistant therapy, but actually the complication is have to have pituitarism, and some study prefer radiotherapy than surgery, and other prefer surgery than radiotherapy. But actually, guidelines can case specific, case by cases. Some cases will prefer to be sent to surgery, like a patient who have tumor near to the optic chiasma, than the radiotherapy. Thank you. Now, if any questions, I'm ready.
Thank you, Dr. Ahmed Al-Mutawi, for this nice presentation. And now we will go for another presentation in the same session of endocrinology with Dr. Mohammed Batis. Dr. Mohammed, we are happy to have you here together with us for the first time. This is the 6th annual internal medicine webinar in Saudi German Hospital. Dr. Ahmed Al-Mutawi, we are so grateful for you, and you are still with us for the next presentation about approach of thyroid nodules. But now we will take a nice break with Dr. Mohammed Batis about update on management of dyslipidemia. Dr. Mohammed Batis is the first time to be with us today, and he is associate professor and consultant in diabetes and chronic disease management at King Saud University, and he is, mashallah, the chairman of Diabetes Fellowship Program Committee at Saudi Commission for Health Specialties. We are happy to have you here, Dr. Mohammed, and you can start.
السلام عليكم ورحمة الله وبركاته. ما أدري الصوت مسموع؟
وعليكم السلام ورحمة الله. مسموع كويس. Your screen is shared.
Okay. طيب حياكم الله جميعا. First of all, I would like to thank you, Dr. Ahmed, to thank the organizing committee for these invitations. It's my pleasure to be with you. I would like also to thank all the participants. Today, my presentation will be about the management of dyslipidemia. I know that management of dyslipidemia, it's not easy to cover within 30 minutes, but I'll try to be very practical, concise, and to the points. And why we are talking about dyslipidemia? Because
Dr. Mohammed, we still have enough time, so you can exceed the 30 minutes, no problem. Take your time.
Sure. Thanks. So why dyslipidemia? Because I'm sure that all of you have a little bit of confusing regarding management of dyslipidemia. We have different guidelines. We have different recommendations from these guidelines, which make that management of dyslipidemia more a challenge among the physicians. And the issue comes actually after 2013. All of us knows about the update of the American Heart Association's 2013 with the new concept to remove the target of LDL. And this is a little bit more patients on statins. So there was a debate and confusions among the healthcare workers regarding the management of dyslipidemia. And this confusions and debate is not just limited to the medical table, but also extended to the public. If you see the post of the newspaper, you will see that some of the newspapers supporting the statin, and they will promote the use of statins, while the others will be against the statins, and they think that statin will be harmful. So this made actually confusions among the medical professionals, specialties, as well as in the public. And this is a very common question that we see in the clinical practice. Is the reductions of cardiovascular disease will be related to the reductions of LDL? I'm sure that you are facing these questions every day. So what is the answer? If we look for the clinical trials, always our answers comes from the clinical trials. And if we look for all the primary clinical trials regarding the LDL reductions, we will see that the reductions of LDL will help to reduce the cardiovascular events. And this comes from improved trial, from Al-Hat, from CARE, ASCOT, chapter trial, different clinical trials. And if we look for the meta-analysis of these clinical trials, approximately 26 randomized controlled trials, they enrolled more than 169 patients. What they found that for each 40 milligram per deciliters reductions of LDL, that's approximately 1 millimole reductions of LDL, will lead to reductions in any major vascular events by approximately 70 or 22%. Also will lead to any major coronary events reduction by almost 25%, and any coronary revascularizations by almost 29% and 18% in any stroke. So the answer for that question is yes, any reductions of LDL by 40 millimole will lead to reductions of all of these major cardiovascular outcomes. And this is how the guidelines will update their recommendations. What's happened actually in the practice, the guidelines will release their recommendations, then they will look for the key clinical trials, then they will keep updating their clinical guidelines according to the recommendation from these clinical trials or the result of these clinical trials. And since long time, if you remember that before 2013, most of the guidelines, whether the Canadian guidelines, whether the United States guidelines or the European guidelines, they set a target. When they put a target, and always they encourage the physicians to reach that target and to start with the statins. If this target not achievable, then you have the option to increase the dose of a statin or even to add another medication to reach that target. If you see the Canadian guidelines, they set the targets. Sometimes this target might be changed according to the result of the clinical trials. In 2006 was less than 2, and it was continued throughout the period until now to be less than 2. For the American Heart Associations and American College of Cardiology, if you see there was a target 2.6 in 2001. Then in 2004, it was reduced to 1.8 for those with high risk people. We are talking about atherosclerotic cardiovascular disease. Then there was also maintained of that threshold and of that target. However, in 2013, here the confusion made by these guidelines. They changed the concept of management of dyslipidemia. They put four group of statin benefit groups, and what they do actually, they remove the target and they advise the physician to treat the patient according to that classifications. So we end up with two approaches since the 2013. We end up with approach or some guidelines, specifically the American Heart Associations, to support fire and forget approach. And what I mean by fire and forget approach, that you don't need to reach a target for that patients. And they claim that when they built their recommendations in 2013, they found that most of the randomized controlled trial and the systematic review of randomized controlled trials, they don't compare for example, LDL 70 to 80 or 80 to 90, and most of the randomized controlled trials were designed to use high intensity or moderate intensity statin. So they believe that target should not be there, and the management of dyslipidemia should be directed to the benefit of a statin rather than to the target of LDL. However, we have different opinion and different angle of recommendations from different guidelines. For example, the International Atherosclerosis Society, they still believe in target, and they believe that each patient should be assessed, and the risk stratification should be also assessed. And according to that risk stratifications, we should start the patient with a statin, and we might increase the dose or add another medication to reach a specific target. So since 2013, we end up with two approaches that made a little bit confusions among the healthcare providers, whether to use treat to target approach that adapted by the American Heart Associations, or whether to use fire and forget approach that been updated or that been adopted by multiple other guidelines. So I would say that American Heart Associations, they have specific approach, which is fire and forget approach. However, the other guidelines, the Canadian, the International Atherosclerosis Society, the European, and the National Lipid Associations, they adopt still the treat to target approach. So I will not take much time in this slide because this is all the recommendations, which is the American Heart Association's 2013. And the point to bring this slide just to show you how the recommendations of the guidelines and how the history of the development of the guidelines have been addressed in the previous years. So the American Heart Association 2013, they made 4 statin benefit group. The first group, which is patients with atherosclerotic cardiovascular disease, and the definition of atherosclerotic cardiovascular disease: patients with ischemic heart disease, patients with stroke, TIA, peripheral vascular disease, abdominal aortic aneurysm. So the recommendation here is to start high intensity statin or maximum tolerated statin for those patients, especially for those less than 75. If the patient's having LDL more than 190, then again, those people usually are high risk for cardiovascular disease, then you have to start high intensity statin. Those 2 groups considered to be high risk group, so no need to calculate the risk for them, no need to assess the risk, just to start high intensity statin. However, for patients with diabetes, what they recommend in 2013 is any patients with diabetes, whether type 1 or type 2, and the age above 40, then you should calculate the risk according to the bold cohort equations. If the risk more than 7.5, then you can start moderate intensity. However, if the risk less than 7.5, then you can start moderate intensity statins. For the groups that not having atherosclerotic cardiovascular disease or LDL more than 190 or diabetes, and the LDL between 70 and 189, and this is what we see in the clinical practice. Here, the recommendation is to assess the risk. If the risk more than 7.5, the recommendation is to start moderate to high intensity. And this is make the prescription of statin more and more. And a lot of debate, a lot of criticism comes to these guidelines because they are promoting for more prescriptions of statins. So what they did, the guidelines, they classify the statin into 3 different groups: high intensity statin, moderate intensity, and low intensity statin. And what does it mean high intensity? That means this statin will help to reduce the LDL by more than 50%, while moderate intensity statin will help to reduce the LDL by almost 30 to 50%, while the low intensity will reduce the LDL by less than 30%. And only we have 2 medications that consider to be high intensity and lead to reduction of LDL by more than 50%: atorvastatin 40 and 80, and rosuvastatin 20 and 40. However, after the release of that guideline 2013, we have a result of clinical trials of improved trial. This is a landmark trial. What they did, actually, they enrolled more than 18,000 people post-acute coronary syndromes with LDL more than 1.3, whether to use simvastatin plus ezetimibe or whether to use simvastatin. And the end of the trial, what they found that both groups, they have LDL less than 70. I would say the first group having LDL approximately 1.8, which equal to 69, while the other group, which is the combination of simvastatin and ezetimibe, they have LDL 1.4, which is almost 54 milligram per deciliter. So the reductions of cardiovascular events were more and was more in the combination group compared to the monotherapy. And this is back again, the concept is lower is better for LDL. So this pushed the guidelines again to update their recommendation, the same guidelines, the American Heart Associations, and they made a little bit more modifications in their recommendation, and they back of the target of LDL for some group of patients. So what is the recommendation of American Heart Association 2018, and what is the differences compared to 2013? I'll take it group by group. As I said, in 2013, the first group considered to be the secondary preventions in patients with clinical atherosclerotic cardiovascular disease. This group, in fact, when they assess the patients according to the history of multiple major atherosclerotic cardiovascular events, or according to the major atherosclerotic cardiovascular disease and multiple high-risk conditions. So to make it simple, if the patient's having two major atherosclerotic cardiovascular disease, or one major and multiple risk factor, then this patient will be classified as very high risk atherosclerotic cardiovascular disease. You should put the patient on maximum tolerated statin, high intensity statin, and you should aim for LDL to be less than 70. If this not achievable, then you have to add another agents like ezetimibe that approved from improved trial, or you can add extra agents like PCSK9 that approved from also another trials. If the patient's having stable atherosclerotic cardiovascular disease, then you can aim for high intensity statin or LDL to be more than 50%, and adding another medications like ezetimibe and PCSK9 to reach a target to be less than 70. And they make definitions for the major atherosclerotic cardiovascular events. If the patient's having recent acute coronary syndrome within the last year, history of MI, history of ischemic stroke, or symptomatic peripheral vascular disease, these considered to be major atherosclerotic cardiovascular events. The high-risk conditions like age more than 65, diabetes, hypertension, chronic kidney disease, congestive heart failure, or persistence elevation of LDL more than 100, or cannot smoking. So if you have one major and multiple risk factors, and I mean by multiple, that's mean two or more, or you have two major, then this patient will be considered to be very high risk for atherosclerotic cardiovascular disease. And your aim is high intensity statin. If not reaching a target less than 70, then adding ezetimibe plus or minus PCSK9 inhibitors. So the second group, which is the severe hypercholesterolemia, more than 190, the same recommendation, there is no change. Those people considered to be high risk, so you need to start high intensity statin for them. So you need to start high intensity statin for them, which is the LDL when you have patients with LDL more than 190. And as I mentioned, high intensity statin, we have two medications, rosuvastatin 21 and 40, or atorvastatin 40 and 80. And before, in the previous recommendation, there was no target. However, in this recommendations and the update of these guidelines, they assume the target to be less than 100. So if this target is not achievable after high intensity statin or maximum tolerated statin, then you can add another agents like PCSK9 or ezetimibe. So this is the second group. So what's about diabetes? If you remember, the previous recommendations was to initiate statins for all people, initiate high intensity statin for those with risk score more than 7.5, and initiate moderate intensity for those with less than 7.5. However, in this update of the guidelines, what they recommend moderate intensity for all people, no need to calculate the risk. However, if the patient's having more than multiple atherosclerotic cardiovascular disease and the age more than 50, then you might consider escalating the dose of a statin to be high intensity statin. So they made a little bit of change on the recommendations of diabetes. So what's about the primary preventions? Here the controversial. Because of the debate and because of the criticism of the previous recommendation of 2013, they made a little bit of change on this group. So what they did, they recommend still assessment of atherosclerotic cardiovascular disease over 10 years. If the LDL from 70 to 189, then you calculate the risk using the bold cohort equations. If the risk less than 5%, then just risk discussions, enhance the lifestyle modifications with the patients. If the risk from 5 to 7.5%, this is considered to be borderline risk. Again, always encourage for lifestyle modification. You might consider adding a statin if you have multiple risk enhancer. And I will come to the risk enhancer after a while. And if you have risk score between 7.5 and less than 20%, then you have to discuss the risk discussions with the patients and the benefit, the side effects of a statin. And you might consider initiate moderate intensity statin, and still if the patient's on resistance, you might also use the calcium score. And if it's positive, then this will direct you to initiate a statin immediely. If the risk more than 20%, then these patients will be candidate for more than 50% reduction of the LDL, and should be the patient should be on high intensity statin. And what is the definitions of atherosclerotic cardiovascular risk enhancer and the tools that help us to escalate the dose of statins, or to decide about starting or not starting statins? For example, family history of premature atherosclerotic cardiovascular disease for men less than 55 and for women less than 65, or you have patients with persistent elevation of LDL more than 160, metabolic syndrome in the form of high triglycerides or low HDL, and central obesity, chronic kidney disease, chronic inflammatory conditions such as rheumatoid arthritis, some of the biomarkers such as elevated lipoproteins. As you know, lipoprotein little a considered to be one of the atherogenic lipoproteins, still not done in our labs. However, I'm sure that in the near future will be available in the lipid parameters, because considered to be one of the predictor for cardiovascular events. Also, persistent elevation of triglycerides level, and high level of C-reactive proteins. And always, you should remember that before treating patients with dyslipidemia, always rule out secondary causes. We know that we have multiple secondary causes that lead to the development of dyslipidemia and lead to secondary dyslipidemia. Some of the diets, some of the causes that increase the level of LDL, while the other might increase the level of triglycerides. If we summarize the causes of increasing the LDL, we have the saturated fat, excessive saturated fat, diuretics, steroids, obstructions of biliary tracts, nephrotic syndrome, hypothyroidism, obesity, and pregnancy. However, the other causes for the high triglyceride level, carbohydrates diet, and this is a very common why we see patients with diabetes to have high triglyceride levels, because they consume a lot of carbohydrates, and we know that this will stimulate the secretions of very low density lipoprotein and more productions of triglycerides. Some medications like steroids, like retinic acids, nephrotic syndrome, renal failure, diabetes, hypothyroidism, obesity, and of course, alcohol is one of the causes for high triglyceride levels. So always rule out secondary causes before treating any patients with dyslipidemia. So what's about the side effects of a statin? We know that the common unknown side effects of a statin is statin-associated muscle symptoms, SAMS. Malaria is observed in the clinical trial by almost 4 to 5%. And to be honest, in the real world data and the clinical practice, we see the muscle symptoms more common, approximately 8 to 10% compared to the observational studies. So if you have patients complaining from malaria, then you have to measure the CK. If normal, that's mean it's just malaria. If the CK is increasing, that's mean myositis. And you have to be cautious if the level more than 5, and you have to hold the statin if the level of the CK more than 10, because there's a risk for rhabdomyolysis. It's a very rare, less than 0.01. However, this is a very fatal conditions. There was a concerns also from most of the clinical trials regarding inducing of diabetes when you start statins. We know that from clinical practice that when you start patients with a statin, you might increase the level of A1C by 0.2, 0.3%. And this signals come from the Jupiter trial in 2008. And the meta-analysis of almost 13 clinical trials, they enrolled more than 4,200 patients. They found almost 9% increase incidence of diabetes, and the recommendations comes that, and the finding comes that if you treat 255 patients with a statin over 4 years, you end up with 1 case of diabetes, and this is the number need to have. So the risk is there. However, the risk is more with those with risk for metabolic syndrome, especially hypertension, central obesity, and those more prone for the development of type 2 diabetes. So what's about liver function test? We know that statin might induce and increase the level of ALT and AST by approximately just less than 4 and 5%. However, when you should hold the medications when you have increasing level of more than 3 times, so you have to hold the medications. So what's about the other side effects as hepatic failure, memory, cognition? There is associations. However, it's not clear associations. Also, there is concerns regarding renal functions, cataract, but all of these side effects has not been proven. Safety considerations, we know that the recommendations that if you have patients will be started on a statin, no need to measure the CK unless the patient's having primary muscle symptoms or having risk factors for development of myopathy from statins. The routine measurement is not recommended. ALT, it's recommended to measure before starting a statin, and then to be measured when the patient is symptomatic. So what's about the Canadian guidelines? Canadian guidelines almost having the same recommendations. If we look for the primary preventions, they recommend to measure the Framingham risk score. If the Framingham risk score to be less than 10%, then the recommendation is to enhance the health behavioral modifications. However, if the patients having a risk score from 10 to 19.9, or the LDL more than 3.5, and patients with age more than 50 years, and women with age more than 60 years, and the presence of high C-reactive proteins or calcium score, then this patient will be candidate for statin therapy. Or the third group, which is patients with Framingham risk score more than 20%. And the recommendation, again, the same, aim for LDL to be less than 2. If the patient not reaching that target of 2, then you can add another medication such as ezetimibe or other agents. What's about the other group? I would say high risk group, which are the LDL more than 5. This patient should be on a statin. And the second group are diabetes. Those people should be on a statin, of course. And the dose of statin should be high intensity statin, especially for those age more than 40 years, and or duration of diabetes more than 15 years, or patients with renal impairment, or those patients for secondary prevention with atherosclerotic cardiovascular disease, then you have to initiate a statin. And for for this group, you have to aim for LDL to be less than 1.8. And for the diabetes, you have to aim for LDL to be less than 2. And for the LDL more than 5, then you have to aim for LDL to be less than 2.5. If not achievable, you can add another medication such as ezetimibe or even PCSK9. We know that triglycerides, these recommendations from the American Heart Associations doesn't touch triglyceride level, only focus for the cholesterol. However, for the Canadian guidelines, they made recommendations for triglyceride level. And we know that for patients with atherosclerotic cardiovascular disease, and if they have triglyceride level more than 1.5 and less than 5.6, we know that from reduced trial that those patients will benefit from adding high dose of omega-3, or those patients with diabetes and age more than 50 years with plus additional cardiovascular risk factors such as smoking, low HDL, renal dysfunctions, micro or macroalbumin urea. So what's about and the recommendations for adding PCSK9s? We have two medications of PCSK9. We have alirocumab and evolocumab. These medications being proven to be add-on therapy to statin and will help to reduce the risk of cardiovascular disease in patients with established atherosclerotic cardiovascular disease. And the findings comes from two major clinical trials, from 4-year trial that assess adding evolocumab with the statin, that lead to more than 15% reduction of cardiovascular disease compared to placebo. And the finding from ODESI outcomes also support adding alirocumab with the statins with those patients with established cardiovascular disease and having LDL more than 1.8, because it will help to reduce the cardiovascular disease by almost 15%. So what's about the other recommendations regarding triglycerides? Again, there are support to add high dose of omega-3 for patients with established atherosclerotic cardiovascular disease or patients with diabetes and having multiple cardiovascular disease. So if your patient's having atherosclerotic cardiovascular disease or diabetes with more than 2 cardiovascular disease, and the triglyceride level between 135 and to 499, so the patient might benefit from adding high dose of omega-3, 2 gram BID. We're talking about 4 gram per day. This will help to reduce the cardiovascular events. Of course, if the triglyceride level more than 500 milligram per deciliter, your option will be adding fibrate rather than omega-3. You might consider adding omega-3 as the third option. However, fibrate will come as a first line. And this outcomes comes from reduced trial when they add omega-3 with patients with atherosclerotic cardiovascular disease and also patients with diabetes and multiple cardiovascular disease. And they found that there will be a 25% reduction of cardiovascular events for those using high dose of omega-3. So what's about, this is a very common questions from our patients. What's about the primary and secondary preventions and the evidence of cardiovascular benefit from omega-3 from the diet sources and over-the-counter medications, and the recommendations that try to avoid these medications, because there is no strong recommendation to support adding low dose of omega-3, and the support usually comes for high dose and high concentration of omega-3 in the form of eco-spanate ethyl of a dose of 4 grams per day. I think it's still not available in Saudi Arabia. It's available in United Arab Emirates. The name of the company is Fasiba. I think will be available soon. This is the end of the presentations, and we can keep the questions at the end.
Thank you, Dr. Muhammad. It was a very nice presentation. I really enjoyed it. And we have 2 questions. First one, can beta blocker cause secondary dyslipidemia?
Yes, beta blockers is one of the medications that might increase the risk of dyslipidemia, but it will not be significant manifestations of dyslipidemia. We know that some of the medications might induce, when we compare it with steroid, when we compare it with retinic acids, will be major differences. Beta blocker might induce, but it's not a significant manifestations for inductions of dyslipidemia.
Okay, if we have a patient with hemorrhagic stroke and he has dyslipidemia, for how long should we prescribe statin for him? For lifelong or for limited time? And what is your opinion in this?
Okay, so this is a very excellent question, Dr. Ahmed. This is, we face it every day in the practice. So what is the target that we need to hold statins? Is it less than 40? Is it less than 20? We know that there was a concerns about low level of LDL, and this might induce some of the, I would say, complications like hemorrhagic stroke. From obesity trial, from the other clinical trials, we reach a target of 15 and we reach a target of 19. So it was safe. However, the recommendations that if you have low level of LDL less than 40 in some of the guidelines, you can reduce the dose, but do not stop statins. Statins should be continue, and the recommendation should be there for patients, especially up to 75 years, because we have good recommendations for those age group. Unless we reach a very low level of less than 0.5, then you might consider reducing the dose of statins.
Okay, thank you. Also, there is another question about statin-induced myopathy and if there is a complication like rhabdomyolysis or just myopathy. Is it recommended to start routine monitoring for CBK, or it's just when the patient has symptoms suggestive of myopathy?
Okay, so the recommendation for CK is not, shouldn't be routine, a measurement of CK. But what we do in the clinical practice, we do challenge test. So we hold the statins and we measure the CK and we hold the statin and we bring the patients after 2 weeks just to make sure if the symptoms disappear, that's mean this is a statin-induced myopathy. So what we do, we start another type of statin, or even we prescribe the same statin but at lower dose. Those patients with high risk of myopathy, you might measure the CK routinely, because this is considered to be one of the primary muscle disorders. So you can measure it, but as a routine without any evidence of myopathy is not recommended.
I have one patient, he had nephrotic syndrome, membranous nephropathy, and he has suffered from secondary dyslipidemia, secondary to nephrotic syndrome, and he was treated with one of the statins, and he suffered from rhabdomyolysis. It was so severe that he suffered from lower limb edema and even upper limb edema. And when we stopped the statin, he was improving, alhamdulillah. But he was scared of starting the statin again. That's why we started biological therapy, namely Rebatha. Yeah, and he was doing well with me. But is there any chance to start statin again? And if we will start statin again, what is your recommendation, the least statin type or name that make the least myopathy?
Okay, so we know that statins, we have some group of statins that consider to be whether hydrophobic or hydrophilic. And we know that the pharmacokinetics of statins, not all of them will induce myopathy. And we know that the recommendations, that the definition of statin intolerance, when you have trying multiple types of a statin and you end up with at least 2 out of 3, they are not tolerating the statin because of muscle symptoms. There are some of statins that being used and with less side effects of myopathy, fluvastatin, bravastatins, or even rosuvastatin. I'm not sure your patients which was on which type of statin.
He was on rosuvastatin.
Rosuvastatin, yeah, rosuvastatin can be. But in those patients, if it's rhabdomyolysis, you might consider, if the patient's high risk, you might consider changing to other type of statins. But again, for example, if patients having established cardiovascular disease, we know that the benefit comes from atorvastatin and rosuvastatins, especially the high-intensity statins. Other type of statin, they might benefit. However, it will not give us the same benefit of rosuvastatin and atorvastatin. So the best option is biological therapy, which is the PCSK9, Repatha. I have similar conditions. When we started the Repatha, that was the only medications that I would say tolerated by the patients. I tried atorvastatin for that patient was not tolerating. I tried Cristor, rosuvastatin at 5 milligram, not tolerating. I tried also bravastatin was not tolerating. So I tried 3 type of statin not tolerating. I end up with using PCSK9.
Okay, I don't have any other question. And now please take a break, but don't leave us. You have still another presentation. Sure. We will wait for you. Pharmacological management of diabetes mellitus. It will be an overview for management of diabetes. And me, myself, I am waiting for this presentation. I will take a break with Dr. Ahmed Al-Mutawi to know about approach to management of thyroid nodules. Dr. Ahmed Al-Mutawi, you are still with us? Yes.
Assalamu alaikum.
Wa alaikum salam, Dr. Ahmed. Thanks for staying with us, and we are ready to hear from you about approach to thyroid nodules.
نبدأ يا دكتور بسم الله.
دكتور احمد احنا سامعينك كويس وشايفين البرزنتيشن. احنا مع حضرتك، اتفضل.
Okay, I want to thank our committee to give me another chance and opportunity to talk about other category of some endocrine disorder. Actually, is a second also common endocrine disorder, or is can facing even in any modality in general medicine or primary health care with thyroid nodules, and how can approach with that thyroid nodules. Now, what is that thyroid nodule? That is the scarlet lesion within the thyroid gland, and has some radiological distant fat surrounding the thyroid parenchyma, and may be palpable or not palpable. 20% to 75% of population have clinically inappropriate thyroid nodules, 3% only palpable, and the nodule is higher incidence in elderly, in women, and even in iodine deficiency area, or patient have history of radiation exposure. This have high risk for thyroid nodules. Actually, ultrasound is a good modality to detect the thyroid nodule and to estimate the thyroid nodules, and they can up to 70% of thyroid nodule can be detected by ultrasound. The most of thyroid nodule is non-palpable, and you cannot depend on clinical examination to assessment of the thyroid nodule and to take a management of the thyroid nodules. Should all patients, palpable or non-palpable, need to be do ultrasound to confirm and to build up your management depending on the ultrasound guide. Thyroid nodules need to be evaluated if have more than 1 centimeter. If subcentimetric thyroid nodule, no need to be evaluated. Why to estimate it and follow up and screen the patient? Just because the thyroid cancer, is not a common, but is still have risk of thyroid cancer. Around 8% of thyroid of malignancy in the worldwide is thyroid cancer. What actually the thyroid causes of thyroid nodule? The cause of thyroid nodules can be thyroid nodules benign or malignant. Most of the thyroid can be adenoma as a benign, or cyst, or subsequently thyroiditis, so they are collections, or infection to the thyroid. It can be a collection that appear like nodules, or infiltrative to the any disease infiltrative to the thyroid can appear like nodules. Malignancy, there is a 3 papillary thyroid cancer is the most common, then follicular, the most aggressive one. Medullary is rare, but also associated with other cancer and actually some aggressive medullary. Anaplastic is very malignant cancer, or lymphoma. This is the malignant category. Can be also is not a thyroid, actually, is have some parathyroid cyst or adenoma and appears like nodules, or thymoma or lipoma, or appears like, or can be this nodule is actually metastatic to the thyroid. The most common cancer is metastatic to the cancer to the thyroid is renal and breast cancers. The prevalence and higher in in 2 extremities of the age groups, in very young and in the elderly. And children, their high prevalence of thyroid cancer, and actually in that area, Dr. Alias, there is half a nice paper about the malignancy in the thyroid malignancy in the pediatric, and he published some paper about that. Adult less than 30 years old, or patients have history of head and neck radiation, patient with family history of thyroid cancer. How can evaluate it of patient with thyroid cancers? History, family history, need to take a history, then have examination. History, family history of the thyroid cancer to be checked at the family history, because this will guide you to evaluate this patient in high risk or intermediate risk. If patient have previous head and neck radiation, or patient have radiation to exposures, a patient have increased growth, for example, he noticed of neck masses and rapidly growth, or patient have other symptoms like dysphonia, dysphagia, or hyper or hypothyroidism, should this take it history evaluated. After that, most of the patient came with asymptomatic, and I accidentally find this patient have thyroid nodule. He do some CT or ultrasound for other reason and found thyroid cancers, thyroid nodules. After that, need to do examination. If this palpable, to be noticed about the consistency and the size of the nodule, any tenderness, any palpable cervical lymphadenopathy, or any focal cord paralysis. This even you can give estimate about this patient, maybe have high risk patient. After that, all patients who have nodule need to do the TSH, at least TSH. If the TSH is elevated or normal, you can do ultrasound neck. If the TSH is low or suppressed, maybe after ultrasound need to do a thyroid scan to estimate it. This patient maybe have toxic adenoma, and you can treat it as hyperthyroidism. And actually, the whole nodule is very low probability for malignancy. Actually, in the early evaluation, no need to do thoracoglobulin. just in the after in the follow-up of the thyroid nodule or malignancy, for example, after surgery or ablation, you can follow up by thyroid globulin. Calcitonin usually is requested when have medullary thyroid cancers or suspected of medullary cancer, or follow up after medullary thyroid cancer treatment. Now you do the history, the examination, you evaluated the TSH, and you found you have patient TSH is normal or high. You send it for ultrasound thyroid to see and to evaluate what the thyroid nodules, and to see this is true nodules, how is large the nodules, and what the imaging characteristic and what the lymphadenopathy. Actually, the guidance depending on the imaging characteristic can estimate this high suspicious, low suspicious, or intermittent suspicious thyroid nodules. And the ultrasound feature can be highly suspicious of the thyroid or associated thyroid cancers. If this hyperechoic nodules, there is with associated microcalcifications and central opacity, twinkling or P-flow imaging, irregular margin, incomplete hollow, is taller than wide. This is a highly suspicious feature. Low suspicious if have hyperechoic is coarse calcification or peripheral vascularity, spongiform. This is low suspicious, low risk features. After that, the risk of malignancy depends on the ultrasound features. Is highly suspicious and risk of malignancy from 70 to 90 if patients have hyperechoic nodule with macrocalcification or irregular margin, taller than the wide, and this is extrathyroid extension to the muscles, multiple lymph node. Intermittent if have hypoechoic without other feature. Low suspicious if have hyperechoic or semiform hyperechoic with cyst. Very low suspicious of spongiform. Benign if only cyst, pure cyst. And this is the percentage of malignancy. The risk of malignancy increasing when have a feature changes. Highly suspicious sonographic pattern, estimated risk of malignancy up to 90, recommended to do FNA if this nodule more than 1 centimeter. If intermittent suspicious, the risk of malignancy 20%, recommended to do FNA of more than 1 centimeter. If low suspicious and risk of malignancy up to 10%, need to do FNA more than if the nodule more than 1.5. Very low suspicious if the more than 2 centimeter, benign one, pure cyst, no need to do any biopsy. This is tried calcification, depending on the also radiological pattern or radiological features. There is collected score, and depending on that, the risk of malignancy appears. After estimated ultrasound, you see the radiological feature, you calcify the nodule, highly suspicious, very low suspicious, or intermittent suspicious, or benign. Will recommend it FNA depending on the nodules. If the nodule below 1 centimeter, whatever the features, you need to do FNA, except if you have patient with highly suspect, if young age with a symptom, with the family history of thyroid cancer, you can suspect it if FNA even is low below 1 centimeter. But other guidelines is suspected all nodule with less than 1 centimeter, no need to do FNA, just observe. If the nodule is not meeting the criteria of NA, need to be repeated follow-up by ultrasound, 6 to 12 months if sub-centimeter nodules, 1 year if his low nodule with low to intermittent suspicious, 2 years very low risk nodules. After that, we'll send patient to the FNA, usually better to do ultrasound guided. After cytology from FNA, we'll recalcify the patient or the nodule to non-diagnostic or benign or follicular lesion or a TB of undetermined significant, follicular neoplasm, or suspicious malignancy or malignant. If non-diagnostic or unsatisfactory, risk of malignancy is 4 centimeters. Actually, risk of malignancy after surgery around 20%. Benign risk of malignancy 3%. Even after surgical excite, only 2.5 found have malignancy. Atypia and endometrium, risk of malignancy 15. After surgery 14, follicular neoplasm or suspicious follicular is very high, 30% up to 25%, suspicious up to 80% have malignancy, even the surgery is around 70, malignant up to 100 risk of malignancy. In the Bethesda 1 or non-diagnostic after FNA, non-diagnostic is 2 recommended. If need to be repeated FNA after 4 to 6 weeks. If at that FNA, the first one FNA is not ultrasound guided, recommended to do ultrasound guided. If the next one is became normal or benign, we'll follow up the patient by ultrasound. If the next FNA appears malignant or suspect, we'll deal with that accordingly, the new result. These are pictures. If the benign is just to follow up the nodule by ultrasound 1 year or up to 2 years. If the follow-up ultrasound found to the size of the nodule increased by 20%, or patient came with the symptom, need to repeat it FNA. Actually, this is one when that's increased by 20% or have symptoms suspicious in the feature and the new ultrasound, need to repeat it FNA. If not, just follow up the by ultrasound in the next years. In intermittent atypia of endometrium or follicular lesions, this will also have 2 recommended. To do FNA, to repeat the FNA again, or to use molecular testing, or to repeat it FNA. Okay, in that follicular lesion atypia of endometrium, there is 2 recommended. 1 recommended to aspirated FNA and do molecular testing, and molecular testing can guide us to be malignant or not malignant, or just follow up after 6 to 12 week interval to repeat FNA. If you do the first FNA and aspirated some cytology and you send it in the beginning of molecular testing, this is the best pathway. But the difficulty of molecular testing is not available in most of the hospital, and some physician or endocrinologist just follow up repeated FNA after 6 to 12 week interval. If you repeat it, aspirated is benign, just follow up 12 to 25 by ultrasound. If the repeated aspirated came also the same category flux and the flux, just to do molecular testing. If testing unavailable, molecular testing unavailable in your hospital, you can do the typical thyroid lobectomy for both diagnostic and management. In the Bethesda 4, if the patient have FNA came with follicular neoplasm, the range of malignancy up to 40%, they're recommended to do lobectomy for diagnostic and for management. If suspicious of malignancy or the high risk of malignancy, refer to surgery for total thyroidectomy. If malignant, the treatment is total thyroidectomy. This just to summarize, when have patient thyroid nodule, just do the TSH, evaluate by history and examination, do ultrasound, and through the ultrasound you can categorize the patient to the nodule to high risk, high suspicious, intermittent, low suspicious, or very low, or benign. After that, if he's meeting the criteria of FNA, send the patient to FNA. And after if the FNA resolved, if he's non-diagnostic, repeated FNA or just follow up. If benign, just follow up by ultrasound. If unsuspicious or follicular neoplasm, just need lobectomy or molecular testing. If malignant, just total thyroidectomy. And thank you, and I'm welcoming for any questions.
Thank you, Dr. Ahmed Mutari, for this nice presentation. I would like to thank you for choosing this subject to talk about, because sometimes we have incidentuloma, or sometimes we have a thyroid nodule that is discovered accidentally, and to know the exact management and the way for diagnosis is very important. Thank you for choosing this important subject, and thanks for helping us giving this valuable information to our attendees. And now we will go to Dr. Muhammad Batis for management of diabetes, pharmacological management of diabetes. Thanks, Dr. Ahmed. Please stop share. And Dr. Muhammad, the screen is yours. You can start sharing your screen.
Okay. Thank you, Dr. Ahmed, for this nice presentation. I really enjoyed the presentation. Very valuable information. Thanks.
Thanks, Dr.
Muhammad. Welcome back again, and thank you, Dr. Ahmed, for your invitation again. So again and again, diabetes is not easy to cover within 30 minutes. However, I'll try my best to just give you the update about pharmacological therapy, and the floor will be open for discussions if you have any questions regarding the update of diabetes management. So,
yeah. Dr. Muhammad, we have enough time for you. We have about 40 minutes left, so you can take your time. Don't feel that it's only 30 minutes. Take your time, okay?
Sure. Thank you. I appreciate that. Okay. Sure. I'll be more relaxed.
Yes, exactly. This is what I need from you.
Okay. That's okay. Great. So what I will try to address is background information about pharmacological therapy. We know that we have different classes of pharmacological therapy for type 2 diabetes. So I'll try to go through all the background informations. Then I will provide you with some of the update about diabetes guidelines. So what is the update of diabetes guidelines? We just have the release of 2022, the American Diabetes Associations. I will touch on that guidelines. And what is the future therapies? We know that diabetes is progressing specialty, and the medication is not stopping every then and now. We heard about new medications of diabetes. So what are the future therapies that we might face in the future to be discussed at the end of the presentation? So I'm sure that all of you know that the pathophysiology of type 2 diabetes is genetic susceptibility, poor lifestyle. There will be long-standing insulin resistance, and the beta cell will try to compensate for this insulin resistance until reach a barrier of compensation, and then the blood sugar will start to increase. Since long time, we know that the pathophysiology is beta cell dysfunctions and insulin resistance, plus the environmental and genetic factors. And most of the medications at that time were directed whether to improve the insulin resistance in the form of insulin sensitizer, or whether to improve the insulin secretions. I would say whether to provide insulin, or whether to give the secretory GIGS agents like sulfonylureas and meglinotides. So most of the medications were directed according to these two pathophysiology. And if you remember that since long time ago, the classifications of diabetes wasn't type 1 and type 2, was insulin dependent and non-insulin dependent, because the classification was based on the type of therapy. However, after a period of time, we discovered that many patients with type 2 diabetes, they end up using insulin. So the classification were according to the pathophysiology rather than the type of the therapy. So as I said, before 2000, we have very limited classes: insulin, bigonides, which is metformin, sulfonylureas, because most of these classes were obtained and were discovered according to the availability or the known pathophysiology of diabetes at that time. However, after 2000, DeFranzo discovered the omnis octet, I would say the 8 main core pathophysiology of type 2 diabetes. Then they start the medications to come in the market: alpha-glucosidase inhibitors, magnetitide, TZD, GLP-1, DPP-4, and etc. So these medications comes after 2000, after the discovery of new pathophysiology of type 2 diabetes. And this is make the selections of the medication very difficult. As a physician, I have difficulty to choose, especially the second agents, whether to choose sulfonylureas, whether to choose TZD. We have different classes, we have different combinations. It's a huge list of medications. So the selections of the second agents always a challenge among the healthcare providers, especially before 2018, because there was no clear recommendations from the guidelines and the options was open for the physicians. So the selections of the second agents was very challenged at that time. So as I said, just to summarize that before 2000, we have limited options: bigonides, sulfonylureas, insulin. However, after the 2000s, we have multiple classes of medications, and even we have within each class, we have multiple medications. And I will go through all of these classes very quick. So this is the omnis octet. I would say the 8 core pathophysiology of diabetes. They discovered that patients with type 2 diabetes, they have problem in the incretin effects. We know that incretin will be reduced in patients with type 2 diabetes. So they try to find medications that help to improve and maintain incretin system. They discovered GLP-1 and DPP-4 inhibitors. We know that we have problems in the glucose reabsorption in the kidney. So they discovered the SGLT2 inhibitors. We know we have problem in the neurotransmitter. We have problem in the hepatic glucose outputs. We have problem also in the pancreas. And the issue is not just limited to beta cell, but also to alpha cells. We have oversecretions of glucagon. So most of the medications that discovered, whether to work in one pathophysiology or to work on different pathophysiology, and even some of the classes, they might have non-glycemic benefit, will not help to reduce the hyperglycemia, but also will help to improve the renal outcomes. It helps to improve the cardiovascular outcomes. Some of the classes might have other benefit other than glycemic control. So let us take the first medication, bigonides, metformin. Metformin, we have been using this medication since a long time as the first line treatment. There is universal agreement from all the guidelines that metformin is first line medications for type 2 diabetes. We know that it's oral medications, low cost, weight neutral. It primary work by decrease the hepatic gluconeogenesis. Secondary mechanism improve the insulin sensitivity. However, one of the drawback of the medication is the GI abscess, approximately 25-26%, that decrease to up to less than 10% if you shift the patients to the extended release form. Recently, just maybe 6 or 7 years ago, we discovered that also metformin will affect the absorption of B12. So the recommendation is to test for B12 from period to period for those taking metformin, and advise the patient to take the medication of B12 if they have deficiency. Lactic acidosis, very rare. And if you remember that before, we hold the metformin according to the level of the creatinine. However, now the recommendation, you have to measure the GFR, and if the GFR more than 30, then you can continue the medication more safely, and you can have the dose if the GFR from 30 to 45, but you have to hold the medication if it's less than 30, according to the calculation of the GFR. So this is regarding the biguanides. We know that biguanides are considered to be one of the high efficacy medication. It leads to 2% reduction of A1C. Sulfonylureas, we have the old medication, glibenclamide, Dawanil, and now we have the new generation, Glimbride, the Amril, and the gliclazide, the Diamacron. It is oral medication, low cost. However, the drawback of this medication is hypoglycemia, weight gain. There was a concerns regarding beta cell barrier. However, we discovered that maintaining the glycemic control will help to maintain also the beta cell. So this concern was eliminated in the last few decades. So sulfonylureas, we know that it is highly effective medications. It will lead to reduction of A1C by almost 2%. Miglinides is the same concept of sulfonylureas. Sulfonylureas would turn on the pancreas 24 hours, while miglinides will turn on the pancreas within our shorter period, 6 to 8 hours. So that's why we need to take these medications with every meal. If you skip the meal, then skip the dose. The same concerns, hypoglycemia and increased weight, and a little bit more costly compared to the sulfonylureas. And it will be very effective to reduce the postprandial glucose. Again, the same reduction of A1C, we are talking about 2%. Alpha-glucosidase inhibitors, these medications, it helps to slow the intestinal carbohydrate digestions. So it blocks the absorption of carbs in the intestines. So it will help to reduce the postprandial glucose, does not cause hypoglycemia. The problem with the A1C is the GI upset, cause gases and diarrhea, and the frequent using of these medications, and also the low effect of the A1C to reduce the A1C by almost just 0.4 to 0.5%. TZD, all of you know TZD, pioglitazone, and the previous medication was rosiglitazone that withdrawn from the market, and that led the FDA to request all the medications to conduct a randomized controlled trial to assess the cardiovascular outcomes. TZD, it's oral medications. It's one of the insulin sensitizers. It can be given once daily. The drawback and the safety profile of this medication is not good. We know that it causes fluid retentions, heart failure, weight gain, bone fracture, especially for women, and bladder cancer. We know that TZD is a very slow medications. It has very effective reduction in A1C. It leads to 2% reduction of A1C. However, because of the safety profile, is not one of the best, I would say, top options in the diabetes management. Incretin. Incretin, we know the incretin-based therapy, whether we have GLP-1. So once the patients eat carbs, this will stimulate the L cells to secrete the GLP-1 and the GIP. The GLP-1 will be stay in the blood for approximately a few minutes, then will be break down by the DPP4 enzyme. So in order to maintain the incretin system, whether we give the GLP-1 as agonist, as injection, or whether to prevent the enzyme that lead to breakdown of the GLP-1, like the sitagliptin or phalagliptin, which is the DPP4 inhibitors. GLP-1, we have the human GLP-1 analogs like liraglutide, or we have the exenatide-based therapy, like the exenatide, which is one of the early medication of this group. GLP-1, it's glucose dependent, so there is no risk for hypoglycemia. It's very smart medications. So it will work when the blood sugar after meals increase. That's why it does not cause hypoglycemia. It might lead to weight loss, might lead to reduce the blood pressure, and some of the medication shows cardiovascular protective outcomes, and I'll mention that later on. The disadvantage, it's injectable agents. So there is psychological resistance from injections among our patients. So some patients will be afraid from starting this medication. There was a concerns regarding pancreatic medullary cell carcinoma. So the recommendations that any patients with history of pancreatitis or history of medullary cell carcinoma to avoid the medications in general. It's expensive medications compared to the metformin and sulfonylureas. It has non-glycemic benefit as well. It helped to reduce weight, approximately up to 4 kg for liraglutide. It helped to reduce the blood pressure. And from the randomized control trial, we saw that some of the people might complain from increase of the heart rate. The clinically approved GLP-1 in the market, we have short-acting medications and we have long-acting medication. The short-acting medications, we have the exenatide and we have also the lexenatide, whether as a monotherapy or combined with insulin. For the long-acting one, we have the liraglutide, which is the Victoza. We have semaglutide, which is the Ozempic once weekly, dulaglutide Trulicity, and albiglutide from Harmony trial. However, the manufacturing has announced that they will not produce the medication anymore. These highlighted with red, in fact, show a positive outcomes in cardiovascular. And what is the difference between short-acting and long-acting? Once we use the short-acting, usually it will work more on the postprandial. However, once the duration of GLP-1 increase, usually it will target the fasting blood sugar more than the postprandial. It will work on both of them, however, will be more pronounced on the fasting blood sugar. We have now the oral semaglutide, the first oral GLP-1 repulses. It was introduced and it's available in Saudi Arabia. They use a special technique to make it applicable to use this molecule by oral. Very specific way of taking the medication. The medication should be taken in empty stomach with just 120 ml of water, no drinking for almost 30 minutes, and no using not using other medications with the oral semaglutide. It has a good effect on the A1C from 1 to 1.5, and has also similar side effects compared to the injectable GLP-1. So what's about the cardiovascular outcomes trials? If we look for the cardiovascular outcomes trials, we are interested for the MACE, the 3 major cardiovascular outcomes. These outcomes were assessed in multiple clinical trials. We have positive result from leader trial that assessed liraglutide. It lead to reduction of cardiovascular in the MACE by 13%, semaglutide by almost 26%, dulaglutide by almost 12%, and albiglutide from Harmony by almost 22%. However, from Pioneer trial, the semaglutide oral, there was reductions. However, the reduction was not statistically significant. So when we are talking about the benefit of this class on the cardiovascular outcomes, in fact, we are talking about liraglutide, semaglutide, dulaglutide, and albiglutide. And in Saudi Arabia, we have liraglutide, semaglutide, and dulaglutide. So what's about the DPP-4 inhibitors? We have different medications. We have linagliptin, we have sitagliptin, faldagliptin, saxa, and alogliptin. All of them sharing the same glycemic control. There is no major differences between them. However, there are some of the unique feature for some of them. For example, linagliptin, we know that it's excreted in the feces. So it's preferred in the renal impairment because we don't need to do dose adjustment for patients with renal impairment. We have a concern from alogliptin and saxagliptin because there was a signal for heart failure. So we always trying to avoid these 2 medications. However, when you want to select one of these medications, remember that the glycemic control will not be different between all of these medications. DPP-4 inhibitors has good safety profile, has no risk for hypoglycemia, weight neutral. There is no drug interactions. There was a concern for pancreatitis. And as I said, heart failure was a concern for saxagliptin mainly, and a query for alogliptin. When we compare DPP-4 inhibitor with GLP-1, we know that the DPP-4 will reduce the A1C by almost 1%. However, the GLP-1 will reduce the A1C by almost 1.5%. This medication works on both fasting and postprandial. We know that GLP-1 longer duration works mainly on the fasting, while the shorter durations works mainly on postprandial. It leads to weight reductions. For the weight reductions, we know that semaglutide may be considered to be the best for weight reductions among the group, followed by Victoza and then dulaglutide. Blood pressure also will be reduced. The main concerns about GLP-1 is the GI abscess. 20% of the people might stop the medication because of the nausea, vomiting, and the GI abscess. And that's why we are not in a hurry in escalating the dose. We are always gradually escalating the dose to make this medication acceptable for the patients. And again, the cost is a major issue in this class. Sodium glucose transporter inhibitors, it doesn't have any risk for hypoglycemia because it works in the renal, so does not cause hypo. It leads to weight loss because it will lead to excrete glucose in the urine. So we are talking about excreting 200 to 300 calories per day. We are losing approximately 2 to 3 kg when we are using these medications. It might help to reduce the blood pressure, and also some of the medication shows a positive cardiovascular protective, especially Imba and Cana gliflozin. The drawback of this medication, it might increase the frequency of genital infections. This medication approved in 2013, so we have limited long-term clinical experience, folium depletions, and the recommendation always try to avoid the medication before Ramadan, especially in hot seasons. We reported some of the euglycemic DKA, very rare, but can be happened with this class of medications. We have 3 types of medication: dapagliflozin for SEGA, and we have canagliflozin, Infocana, and we have Imba, Jardiance. And it comes in different doses, and the A1C reduction range from 0.5 up to 1% for the canagliflozin. Weight reduction also range from 1.8 up to 2.8. Also, the systolic blood pressure might be reduced. Always remember that the genital infection and UTI might be possible and side effects of this class of medications. What's about the cardiovascular outcome trials? When we look for the MACE, we have a positive result from EMBARIC, 14% reduction of cardiovascular events. And also we have positive result from CAMFAS program, 14% reduction of cardiovascular events. We didn't see this from DECLARE TIMI for dapagliflozin. When we look for the other part of cardiovascular, for the hospitalization of heart failure, we will see that it's a class effects. So empagliflozin, DAPA, and CANA lead to decrease the hospitalizations of heart failure. So it works good with heart failure, and it's recommended to initiate this medication for those patients with the heart failure and with the reduced ejection fractions. Also, it has a positive impact on the progression of chronic kidney disease. This was observed from DAPA, CANA, as well as empagliflozin. So beside the reductions of MACE outcomes, we have a positive impact on the hospitalization of heart failure and then the progression of CKD. So this is a very common questions, which second agent to add. We face it every day in the practice. We know that we have universal agreement between all the guidelines that lifestyle modifications and metformin considered to be the best or the first option. Most of the guidelines, there are some exceptional guidelines. However, most of the guidelines, they enhance starting patients with lifestyle and metformin as a first line. However, when it comes to that, to the second agent, before we don't have recommendations. However, now with the updated guidelines, we have very clear, I would say, instructions for the physicians how to select the second guidelines. Let us see the American Diabetes Associations. What is the change in 2022? The guidelines, in fact, again, they recommend that when you prescribe the medication, you have to assess the efficacy of the medication, try to choose the medications that lead or to be effective. For example, do not use GLP alpha-glucosidase inhibitors, 0.4% reductions of A1C. However, we know that metformin, sulfonylureas, GLP-1, insulin, TZD, it has high efficacy medications. Also assess the risk of hypoglycemia, assess the risk of weight. Hypoglycemia, we know that most of the medication does not cause hypoglycemia except for sulfonylureas and insulin. Weight, again, very important. And some of the patients prefer to use the medications that lead to weight loss. And we have two well-known medications that help to reduce weight, SGLT2 inhibitors and GLP-1 agonist, the injectable agents. And also the oral agents might help to reduce as well the weight. Cardiovascular effects, whether in the form, whether directed to the atherosclerotic cardiovascular disease risk, or whether directed to reduce the heart failure hospitalization. We know the benefit comes from, mainly comes from SGLT2 inhibitors. For the cost, we know that there are some of the medications highly cost, like SGLT2 inhibitors, GLP-1, DPP-4 inhibitors, as well some type of analog type of insulin. For the renal effects, we have some of the medications that proven to slow the progressions of renal impairment, mainly the SGLT2 inhibitors. So this is how to approach our patients from the ADA to 2022. Always start the patient on metformin plus lifestyle modifications. Then you have to assess the atherosclerotic cardiovascular disease, or the indicator of high risk for atherosclerotic cardiovascular disease, or whether the patient having heart failure or CKD. So if the patient having atherosclerotic cardiovascular disease indicators, or having indicators of high risk for atherosclerotic cardiovascular disease, then try to select a class beside metformin that proven to reduce the risk of atherosclerotic cardiovascular disease. So we end up with GLP-1 or SGLT2 inhibitors. If the patient having heart failure, then the option would be SGLT2 inhibitors, because we know that it's a class effect. Most of the SGLT2 inhibitors proven to reduce the hospitalization of heart failure. For CKD, always the option comes for SGLT2 inhibitors. Again, we have positive also result for SGLT2 inhibitors. We have some also potential benefit from GLP-1 if the SGLT2 inhibitors cannot be used. To minimize hypoglycemia, we have medication proven that does not cause hypo, DPP-4, GLP-1, SGLT2 inhibitor, and TZD. And for weight, as I said, GLP-1 and SGLT2 inhibitors will be a good options. And when the cost is an issue for some of you working in the, for example, primary care settings, so the availability of medication will be obstacles, the cost will be obstacles, so you can choose medications that are cheap and available and affordable for the patients. So what's about if you start a second agent and still the blood sugar not control and the glycemic not control, then the option is to add a third agent, and usually the preferred agent will be injectable. Always consider GLP-1 as injectable agents. And if you add the GLP-1 as injectable agents and still the A1C not in control, then the basal insulin will be the good options for the patients. And always the question comes, until which dose I should increase the basal insulin before considering them for rapid. And the recommendation always, if you reach 0.5 unit or 0.6 unit per kg and still the blood sugar not, the A1C not controlled, then you can aim for adding prandial insulin. So what's about the diabetes, the Canadian guidelines? The Canadian guidelines almost share the same concept. Always advise for lifestyle modifications, metformin, and assess the patients after 3 months. If the patient is still not on target, again, the same concept, assess patients for atherosclerotic cardiovascular disease, kidney disease, heart failure, or patients with age more than 60 years and having multiple cardiovascular risk factors. If you are aiming, if patients having established cardiovascular disease or renal disease, then you can choose medications to reduce atherosclerotic cardiovascular disease. The good option will be GLP-1 or SGLT2 inhibitors. For CKD progressions, then SGLT2 inhibitors will be the best options. And for heart failure, we know that SGLT2 will be good options. And for those with high risk, GLP-1 with good options, and particularly dulaglutide, because we know that from REWIND trial, majority of patients were primary prevention. So many of them, they were more than 60 years with multiple cardiovascular events, and the trial has a positive impact on those patients. Again, if the weight, the main concerns, GLP-1 and SGLT2 inhibitors, hypoglycemia, try to avoid these medications. For weight gain, try to avoid the TZD, and the risk of heart failure, as I said before, saxagliptin, alogliptin was considerable during the clinical trials. So what's about the American Associations of Clinical Endocrinology? 2020, they share the same concept, and they made the classifications according to the A1C. If your patients having A1C less than 7.5, so the monotherapy will be metformin. If metformin contraindicated, then you might consider GLP-1 and SGLT2 inhibitors or DPP-4. They make the recommendation according to the hierarchy of the evidence. And if the patient's having established cardiovascular disease or CKD or heart failure or renal impairment, then the option you should consider GLP-1 or SGLT2 inhibitors. If the patient having A1C more than 7.5 and less than 9, then the option to use double therapy, metformin plus GLP-1 or SGLT2 inhibitors or DPP-4. Triple therapy, again, the same. And if the A1C more than 9%, always if patients having A1C more than 9% and symptomatic with catabolic stage, of course, insulin will be the first options. However, if the patients can tolerate oral medications without catabolic stage, you might consider double therapy or triple therapy according to the recommendations. So this is a comparison between these guidelines. As you see, there is no major differences between the recommendations. All of them direct and encourage the assessment of atherosclerotic cardiovascular disease, heart failure, renal impairment in order to decide whether to choose which medications to be used as a second agents. So what's about the future therapy? I'm sure that we will face many future therapies. Some of the therapies might be directed to the diet, probiotic, and there are talk about gut microbes that help to improve the glycemic control. We know that SGLT2 and SGLT1 and 2 inhibitors might work in the intestines as well. So a lot of work regarding the combinations or targeting the SGLT1 and 2 as well. There are some of the incretin mimetics and small molecule receptor agonists. They are working to enhance, and we know that they discover oral GLP-1 and still incretin system. We might face in the future new mimetics. They are working in tissue selective smart insulin. This is a very great idea. They are working in a smart insulin that it works when the blood sugar is increased and stop working when the blood sugar is low. So we might in the future see smart insulin. Even the route of administration might be available. We heard about the inhaler insulin. We heard about the oral insulin. We might face even different route of administration of insulin. There are some of the trial working in glucagon receptor antagonist as well to reduce the secretion of glucagon. As I said, one of the pathophysiology of type 2 diabetes is alpha cell will secrete more glucagon. We have a class of medications that work on this, which is the GLP-1 and the incretin system. However, they might discover direct glucagon receptor agonist. Also, they are working in a small molecule of insulin. Some of the medication might work on glucokinase activator as well. Some might work on the novel SGL2 inhibitors. So the future is there. We expect to see more and more medication, to see even new class of medications, or even to see new medication within each class. I think this is the last slide of the presentations, and thanks a lot for your listening.
Thank you, Dr. Muhammad. I really enjoyed this presentation from the first slide till the last slide. We have two questions here. The first question regarding vitamin B12 deficiency and treatment with metformin. He's asking, do we have to correct it, or we have to wait for the level of B12 in the blood?
Okay, so I think we are over correcting B12 for patients with type 2 diabetes. The recommendation is to screen for B12 deficiency from period to period, or the patient symptomatic. If you have B12 deficiency, correct, back to normal, stop the medication. We don't want to over-correct B12 and lead to toxicity of B12. And there is a misconception among the patients and even among the physicians that every patient with metformin should be on B12. And this is not right. If the patient's having deficiency, correct. Back to normal, hold, and screen the patients for B12 deficiency from period to period. And I think from this table, I think we need to increase the awareness even among physicians that patients shouldn't take B12 as a prophylaxis. Always encourage taking the B12 when there is a deficiency.
Do you like to correct with oral or parenteral?
You can correct both ways. Injectable, of course, will give quick corrections. However, we know that, and we have good evidence that oral also it works for the corrections of B12 from metformin use. So you can use both metformin, oral, yeah, and parenteral.
It doesn't matter. Yeah. Okay. How do you think about using Ozempic for weight loss? Is it justified and ethical?
Okay.
This is we are doctors here, and they can ask about something. Maybe he's facing this issue in his practice.
Okay, I'll talk. I will not say Ozempic. I'll talk about semaglutide. Okay. We know that semaglutide, from the clinical trials, the weight reductions with semaglutide, it will lead to, I would say, better than Victoza, of course, better than liraglutide from the clinical trials. So semaglutide in the dose of Ozempic, it will help to reduce the weight by approximately 7 kg, which is comparable to Saxenda, to Victoza, or to liraglutide at 3 milligram. We know that from the recent clinical trial that published almost 1 year, that Wegovy, which is the higher dose of semaglutide 2.4, will help to reduce the weight more than 10 kg, and it's approved. Wegovy, it's approved. So it's the same practice that we did with Victoza. Victoza, we know that Saxenda at 3 milligram before it was available in Saudi Arabia. We used Victoza as 1.8, then 1.2 as a dose of 3 milligram. It's approved. So if the patient can use it, I think it's okay, because we have strong evidence from clinical trials. It's approved for FDA that Ozempic can be used for weight reductions, but still it's not approved in the Saudi FDA. We are waiting for Wegovy to be available to be the main, I would say, medications to be used for obesity. I hope that I answered the questions.
Okay, it is clear. In the practice, do you notice that some patients on SGLT2 inhibitors having more urinary tract infection?
To be honest, yes, I see. But when you read the clinical trials and the evidence, we know that the UTI is more in the Western community. Alhamdulillah, we are in the Muslim community. We have less UTIs compared to the Western community. So we see it in the practice, but less than what being reported in the clinical trials. So it's there. Yes, we see it in the practice, and you have to observe, and you have to monitor, and you have to treat the patients once there is a UTI. But it's less compared to the Western community.
Okay, from my side, as a nephrologist, when I have a resistant or recurrent urinary tract infection, I stop these medications.
Excellent.
It helps in reducing the recurrences, especially in older females. Anyhow, thanks for this nice presentation. We really enjoyed, and thanks again for the dyslipidemia, and thanks for joining us. And today, this is the end for today. It was a very nice end. And thanks, Dr. Muhammad. Thanks for all the attendants who started from the first beginning at 4 o'clock till now at 9 o'clock. I hope everyone enjoyed. I just want to announce that those who are joining for free, if they want to have CME hours, they can contact Mr. Tamer in the organizing committee. His phone is there for everyone. And thanks for the organizing committee and those who helped us here in Saudi German Hospital, Mr. Tamer and his team. Thank you. And we will close for Shukran. Shukran. We will leave.